Good morning to everyone. Make sure we can be heard here. Does everything look all right? Good morning, everyone. On behalf of the Mental Health and Vulnerable Adult Task Force, myself, Lloyd Larson, a representative from Lander, and Senator Fred Baldwin, who co-chaired this committee. Fred's from Kimmer. We'd like to welcome everybody who's with us today. We've got a full agenda, including a tour of the children's home. We will be taking some pretty significant steps in some issues on vulnerable adults in the K-12 model that we've been working on now for a couple of years, trying to finally get into some milestones there and moving some of those recommendations forward. So we'll have a busy day today. We've got a number of our task force members participating online, and we have a couple en route. We'll, as we call roll, we'll excuse Senator Nethercott and Chairman Zwanitzer, who are en route. We'll look forward to seeing them later. So with that in mind, Clarissa or Anna, whoever, if you go ahead and call the roll, we'll get started on today's meeting.
Good morning, Mr. Chairman. This is roll call for the Mental Health and Vulnerable Adult Task Force for August 1st. Senator Barlow.
Present.
Oh, there he is.
Senator Nethercott.
Excused.
Speaker Summers.
Here.
Representative Zwanitzer.
Excused.
Director Johansson.
Here.
Director Schmidt. Present. Director Shannon.
Here.
Mr. Brown.
Here.
Ms. Butler. Co-Chairman Baldwin.
Here.
Chairman Larson.
Here.
You have a quorum, Mr. Chairman.
Thank you, staff. And just as a little information for those who may be watching and not familiar with the makeup of this task force, generally during the interim, we have when we have subcommittees or standing committees doing interim work, those are made up completely from the standing committees of the legislature, with members all being either from the House and the Senate side. When we have a task force, we can include non-legislative members, and as we've over the last couple of years, as we've addressed the issues on mental health and defined them to some degree, we've asked for participation from our judicial system and from our agencies, including Department of Corrections, Department of Education, Department of Health, and the Department of Family Services. So you'll see those representatives here with us. And if you've wondered why, that's kind of the makeup of this committee. Hence, this task force cannot bring forth legislation to the legislative body. We can bring forth bills, and we will pass a draft of a bill, but then it has to go to a standing committee. We've referenced a couple of bills, or we referred, I should say, a couple of bills thus far to the Joint Judicial Committee. They'll consider those and make a determination whether to move those forward in the next legislative session. And we've got probably 2, 3, could even be 4 more bills by the time we're done in this session. So with that understanding, we'd like to get started on today's meeting. And will be the first topic up this morning and it's the first thing in your agendas, is the essential services for the vulnerable adult. And before I ask Director Schmidt to kind of walk us through this a little bit, we've had over the last year, and really focusing this year, trying to identify what the state's role is to ensure that what services are available out there to vulnerable adults when they're in a compromised situation, either from a mental illness, abuse, or vulnerability. Ooh, is a big word. That's more than 3 syllables. And that really is a gap in our adult protective service definition, and it's a gap in how the Department of Health, Department of Family Services, and work together as we try to coordinate guardianships where needed and services where needed. So we are trying to today, from this task force, make a statement and that we'll bring forward and says, as a state, our policy is that we feel the state has a role in providing these services, then we'll have to come back and we'll talk a little bit more about this after we vote on each of these and after Director Schmidt talks to us. But then we'll have to move on to the next major step, which is how then do we provide those services and what opportunities are there that already exist with current funding models? And then is there a point where we need to make, as we define the program, would we need then to make a request for additional funding somehow at some point? But to say that now would be premature. So with that lead in, Mr. Chairman, would you like to make any comments before we turn it over to Director Schmidt?
Thank you, Mr. Chairman. I've just thrown in one comment, and you've already heard me say this before. You and I were able to recently attend a screening of a film done by one of our organizations in the state. The sound has the initials of peanut butter and jelly with one difference. And that would be a film called, or representing a series called State of Mind. And the latest one had a lot to do with dementia and had a lot to do with Alzheimer's. And I would highly recommend that for anybody in the audience that hasn't seen that, to tune into that online, because it's very effective and it's very illustrative of some of the things we're talking about here today. That's all I have. It's good to be here. Carry on.
Thank you. And I apologize for pontificating excessively this morning, but I would also, just for those who are watching and the task force members, this summer, as Chairman Baldwin and I attended a national mental health conference and a couple of other conferences where I've met with colleagues from in other states and talk about this whole coordinated effort to address mental health, going from our state hospital, our ICF, our children in schools, and what the state of Wyoming has done over the last 10 years to this point. I would just suggest, and it is my opinion, that we really are out in front of many of our neighboring states and many states across the nation in trying to coordinate services, define policy, and implement policy for the benefit of the citizens that are struggling with these types of conditions in their lives. So with that said, Fred?
Just one more quick word. If you can pontificate, I guess.
Yes, you can.
Just a note that the governor's initiative right now on mental health and suicide prevention is just going out. I know in Representative Summers, Speaker Summers' hometown there, there's a series coming up on suicide prevention, and that will be going across the state. And that's something else. And Ms. Davis could talk to that further, but that's something else I think that people need to pay attention to. That's coming across the state now. And I expect that Speaker Summers will be at his. I will try to be there as well, but that's important stuff as well.
Yeah. Director Schmidt.
Thank you, Mr. Chairman, Mr. Co-Chairman, members of the committee. I would like to do a little bit of level setting before kind of walking into the essential benefits conversation, and a little bit of a recap over the last couple of years. So much of this conversation has really been about what is the role of the Department of Family Services and Adult Protective Services in serving this population. And we've talked about this population in a lot of ways. We've talked about this population in terms of people who have possibly been abused or are suspected of abuse or financial exploitation or of neglect, including self-neglect, all the way down to people who are either young or elderly that need access to services to be able to provide them with an opportunity for a continuous life. And specifically with that population, it includes young people, young adults who are transitioning from a child system into an adult system, but still need support like housing, like case management, who are unable to live completely by themselves without some level of support, but yet do have some autonomy. So the struggle in the conversation, I think, has been very fruitful, especially from the department's perspective, in that really understanding what the role of our agency is and what the role of community is. And in conversations with Director Johansson, thinking more intently and deliberately about the intersection of services with people who have either at risk of vulnerability or are vulnerable. And that's a really gray area. And as we've tried to articulate the difference in those populations, it really blends one into the other, because once you're at risk, it doesn't take very long to then become vulnerable. The issue for a long time has been, though, that the Department of Family Services is responsible for investigating those concerns, those allegations. However, it doesn't have the finances or the funding for the services that are necessary maybe to intervene in a long-term way. Short-term, yes, we do have some ability to intervene in a very fast manner, provide some direct support, but it's not for ongoing purposes. That then comes back to the community and the role of the community and all the services that are gathered there by the community on behalf of the community to better support those vulnerable adults. Again, whether they be young adults or they be the very elderly. And I think that's the crux of the conversation. The chairman referred to the proposed essential benefits, which was a handout that we started discussing at the last meeting. And this was a long conversation between our agencies that looked at data, that looked at spending patterns, that looked at needs as described to us by adult protection teams, by workers, by other stakeholders. And essentially, the issue is these services are what we've identified as basic services that vulnerable people or people at risk of vulnerability should have available to them in a community so that they can continue for what the Department of Family Services is after, is living safe at home for as long as possible. The issue is, though, is that we've not ever decided as a whole, the policy statement has never been made, are these essential first? Because these are assumptions based on the work that we do. But from a policy perspective, are these the services that we think are essential? And then after that, who should be responsible for A, funding those services and or B, providing those services? So I do think we're at an interesting juncture now in terms of making some decisions, which then sets the tone for the work that the Department of Family Services does, the work of the Department of Health, and all of the other stakeholders that we work with, whether it be at the state level or at the community level, to really create a system, a community system that provides support to all of these folks. So with that, Mr. Chairman, I think the conversation then starts to discuss the essential services.
Yes, and so I think the way I'd like to do this, Director Schmidt, is first just remind the task force members that the Department of Family Services put together with the Department of Health an extensive matrix. Remember that big matrix of all of the services that the state that is provided to adults through varying programs, and then how much of that as you look at those, how much of that is funded through each agency. And then we ask the agencies to take that matrix and refine it down to what they feel are these essential services, which are the ones that we have listed on your handout on table 1. And what I'd like to do is have Director Schmidt or Director Johansson, it doesn't matter to me, they can work that back and for themselves. Define, we'll go through one by one. And then at the end of at the conclusion of each one, I'd like to vote as a task force saying, and the question is, does the state have a role here? Is this essential service something that the state has a role in helping to provide? The second question on who's responsible, I think we can, I think we'll leave that maybe to see how we further develop that. But I think we'd ask at this point where those responsibilities on that matrix lie as you explain it. And then we may further define that in future meetings to give more definition as we see what resources available and where that better fits. But I think the vote today will be, is this an essential service? Now, for the members of the task force, this is not a new way to do that. As we looked at the behavioral health redesign when we went back and was deciding what the state's role for providing services at the Life Resource Center and the state hospital, we done a similar exercise but this, as we establish policy, we need to understand that or have the feeling that we're all on the same page. So that's the intent of this exercise here this morning. So let's start with safe housing, Director Schmidt, what that means. And then I would just follow up when we get to the end of this, if there's a service that somebody on the task force feels that we've overlooked and need to include, we want to have that conversation as well. So Director Schmidt.
Thank you, Mr. Chairman. Safe housing is a tricky one, because what is safe and then what is housing? Is that temporary? Is that permanent housing? And from a vulnerability standpoint, from an emergency services standpoint, what we see as an agency oftentimes is that a person is living in a home that is unsafe. And it may be unsafe because of hoarding. It may be unsafe because there's somebody living there, a relative or someone who is potentially or is abusing or neglecting the vulnerable adult. But then there's also long-term housing that comes oftentimes with young people who are, as I said, transitioning from one system, whether that be the child welfare system or the DDID, intellectual disabilities, developmental disability system, into adulthood. And so this idea about safe housing really does depend on who we're trying to serve. But like all the communities, I think, are experiencing housing, there is a shortage of housing. And then when you have populations with specific needs that maybe have some sort of physical disability or developmental disability, then the housing for that kind of population is even more limited. So this is a big conversation. I know the governor's office and many of the agencies, many of the legislators and communities have had a lot of deep conversations about this. Our purpose, though, is to help folks remember that there are some subpopulations that are much more at risk, that also need housing, and what is the obligation of our collective state or systems to support that housing. So this one is one that varies from long-term permanent housing to short-term for those people that are developmentally disabled or intellectually disabled and at risk, all the way up to those that need some brief housing moments so that we can work together to address whatever the issues are in the home that are keeping that person from living safe at home, whether that be because of relatives or the conditions of the housing.
Questions from members of the task force?
Mr. Chairman,
Please, Director Johansson.
thank you. I agree with Director Schmidt. This is a tough one because traditionally, providing housing even to specific populations in a definition like a vulnerable adult or any safety net population has been a tough decision. Is that a direct role of the state to provide, create, purchase housing? And generally speaking, the answer has been no. As I worked through the matrix here that we presented last meeting and developed between the two agencies, I can kind of see it in two different pathways. One, if you'll look at the paragraph prior to the table, or a couple paragraphs prior, looking at the definition of what we're talking about as a vulnerable adult is someone with an open vulnerable adult case. So something that Department of Family Services is investigating and often finds issues immediately that should be addressed even before, and this is probably not the right term, Director Schmidt, but a individual is confirmed or adjudicated or what have you as vulnerable adult, through the Adult Protective Services case. There's kind of two avenues there. One is this, like I mentioned last, this is a vulnerable adult. And then we're investigating this case to determine vulnerability. I thought through these, 6 or 7 service areas in both of those contexts to develop at least my recommendations for the state's role in that. When it comes to clients who have been determined vulnerable, there is abuse, neglect, unmet needs, inability for self-care, et cetera. Then I do believe there is a role on a time-limited emergency basis for the state to provide services that could improve the situation. For a broader population, in terms of the housing issue, that's really where I come back to the role of the community, the city, the county, of what is available. And sometimes those are intermingled with state resources, housing resources, et cetera. And I didn't see as much of a role for the state there. Housing is a very tricky topic. Director Schmidt mentioned the shortage and the cost that we see. Even trying to staff our state facilities, it's difficult to recruit entry-level workers because finding places to rent, finding places to buy is sometimes cost prohibitive. I see that as a problem with this committee's recommendation. If safe housing across the board for suspected vulnerable adults or confirmed vulnerable adults were a role of the state and assigned to an agency, your economic problem of scale will be very challenging in communities across Wyoming. How do you program that? How do you fund that? What are the moral hazards associated with the way to get safe housing is to become a vulnerable adult? There's many philosophical problems, but just to get the ball rolling, Mr. Chairman, for this particular category, for those who are confirmed as vulnerable, I did see a state role there in the types of emergency services that the Department of Family Services provides currently. Potentially expanding that and expanding that funding source. And then secondly, with housing and some of the populations that Director Schmidt mentioned, this is where I think between now and the next meeting, we could flesh this out between the agencies and with the task force, leveraging current programming and eligibility that has housing components to it, not comprehensively, but Director Schmidt mentioned our comprehensive and supports waivers for those with developmental and intellectual disabilities, a Medicaid program that can support some of those needs on the long-term care side for the community choices waiver for those who are nursing home eligible but served in the home should they elect to apply for that program and be found eligible. It does have restrictive eligibility standards. You must meet nursing home level of care and Medicaid financial requirements. There are things within home services, environmental modifications, things of that nature that can improve the living situation. So twofold for me, emergency time limited basis, looking at that for confirmed vulnerable adults and potentially expanding the reach of the Department of Family Services and Health through the ancillary programming of already operational programs and eligibility that we have for those populations.
Thank you. Other comments?
Mr.
Questions?
Chairman,
Please.
Speaker Summers raised his hand.
Speaker Summers, thank you. Didn't see your hand. I see it now.
Mr. Chairman, thank you. I'll be a little delayed because I'm on a satellite feed. So two things. One is on the safe housing issue as it relates to the state's role. I think certainly that emergent housing need when somebody is found, when law enforcement or whoever finds an individual that is in a bad situation, a vulnerable adult in a bad situation, I think we need to have the ability to put those people in a safe place temporarily. And I do believe the state has a role in that, whether that role is just helping fund some local efforts, I'm not sure, but I do believe the state has a role in that. And then the other issue, which maybe this isn't a vulnerable adult, but the developmental and intellectually challenged, I guess, developmental disabilities and intellectual disability individuals who are in their home, and I think of one in my area with a parent who's now nearly my age, right? And so the child is probably in their 40s, and at what point does the state step in and provide enough services that mother who is now approaching being, on Medicare, frankly. At what point do we as the state step in and help that individual more than we do now? I think we are challenged to help those people to the level that it needs to be to help them remain in the home. And if they are not in the home and if they're not being taken care of, then they will be ultimately dealt with by a system that we, whether that be the law, law enforcement, the courts, whatever. And so I guess that's my gist. I think we need to see if we can take care of the developmentally disabled caretakers a little better. I don't know how we do that. I don't know what that looks like, but I do believe safe housing at that moment when a vulnerable adult is found in a home, we, the state, need to be able to help ensure that temporary housing until matters are taken care of.
Thank you, Representative Summers. Further questions, comments? So before we vote on this, and I would just note, and it's interesting because we come down to 3 or 4, we get into case management, and to Representative Summers' comments, when you have somebody that's maybe living at home that's intellectual or developmentally disabled, do they have access to a case manager? Because you would hope that they are already, we have a mechanism there to help provide for them through the support waivers, and if need be, a comprehensive waiver. But are they already included in that, or are they even identified and being on the wait list, which really comes back to the importance of this case management. So to Representative Summers' point, we have some pending needs on housing, but to make sure that stuff like this is available to them, making sure that they are aware of the resources available, such as waivers, such as the community choice waiver on long-term care, plus the getting the LT 101 rating if your evaluation before you to assess whether you qualify for long-term care as a vulnerable adult. So I think we'll see a nexus between all of these as we move forward. So in that, but I think the comments made really identify that from Director Johansson is that we actually have some programs in place now that provide long-term and short-term housing as we qualify, and then and so we're not without resources now. It's just coordinating the efforts to make sure that people are aware and getting them in place. Director Johansson.
Thank you, Mr. Chairman. Just one addition. I do think this is important, and a subtle suggestion to the task force that as we work through this state role, it's not bifurcated in my mind, meaning if you say, yes, there's a state role, it means that there's something new, because we do have, albeit imperfect, there are programs. And if you go consult that massive spreadsheet that we talked about at the first meeting, you can see where those services are, what they are, who they're provided by, and how they're funded. And that's what I think is important in this question of, is there a state role with safe housing? There's 2 questions there. Is there a macro state role? And that can include things that are already being done. Is there an expanded state role based on the knowledge of this problem that this task force has worked through when folks are identified or suspected of being vulnerable through adult protective services? That to me is the crux of this issue. Is there an expanded role to do something additional or new for this particular population? And then ultimately, who would be responsible for that? But it's important for me, for the task force to know that, again, not comprehensively, but within program criteria and eligibility categories, there are support systems in place depending on the characteristics of the individual or the population that would be in question.
Thank you. Well said. So I think Chairman Baldwin will just do this by a raise of hand rather than roll call. But those that feel that safe housing should be an expanded role of safe housing. Senator Barlow, please.
Thank you, Mr. Chairman. Just, and I appreciate your wanting to get to the question, but I just want to make sure I understood. Did Director Johansson and then potentially also Director Schmidt both say that housing is being provided now in some context? So what I guess I'm asking is, are we doing it already? And so this vote is saying, yeah, it's still important. That's just my basic question. Thank you, Mr. Chairman.
So I'll look for a nod from them, but I think the answer to, is it being provided now? Yes, depending on the condition of the vulnerable adult and their circumstances. Now that doesn't, it could be somebody with intellectual or developmental disabilities, or it could be somebody who now is aging out and is not able to, does not need to go into a nursing home, but is having trouble staying at home, and through the community choice waiver might be able to prolong that. And so we have some programs now that provide housing that perhaps some vulnerable adults are not taking advantage of, but there's also a role, particularly as Representative Summers mentioned, on emergent housing, and that we need to expand those housing opportunities is not the right word, but to expand the type of housing and to whom and for what duration. Director Johansson.
Mr. Chairman, thank you. Just adding to Senator Barlow's comments, and again, just the way that my mind is working on this exercise, carving this particular item up into a couple of categories. You'll see in the definition, time limited in-home services, or what in this discussion we've talked about emergent services, when someone is found through an investigation and there are unsafe conditions, either based on the physical structure, the family members or residents of that particular housing environment that need to be changed, need to be addressed on an emergency basis. In my view, with the vulnerable adult population we are talking about, that should be an expanded role in adult protective services to be able to do that on an emergency basis, time limited, temporary, more comprehensively across the state. Secondly, when you look at the latter part of this definition, which can absolutely include there is a vulnerable adult, that long-term housing is a need. And I hate to sound unsympathetic here, but I think it's important for the discussion. In my introductory comments, that is where I would argue that there is not an expanded role of the state for housing stock, housing purchasing, et cetera. I see that as a bit of a policy and economic quagmire going forward of what the state would be able to do outside of current programs like we're discussing, whether those are Medicaid waivers or things that can influence the quality of housing, safe housing, home modifications, things of that nature, or residential services in facilities, nursing homes, assisted living programs that we have through the Department of Health for certain qualifying individuals. So twofold for me, one on the time limited emergent basis that the good caseworkers at DFS encounter these clients, and there is a short-term need, and they work through those within their current resources currently through looking at hotels or temporary relocations while issues could be addressed or further investigated. I do see that as an expanded role of the state, and sorry, Director Schmidt, to throw this to you, but the Department of Family Services, I think it's a trickier question, and my thinking is on an expanded role for comprehensive long-term housing that is not an expanded state role. Thank you.
Senator Barlow, did that? Are you okay there? Okay. So with that in mind, those of you that feel that safe housing is, as we've discussed here today, the state has a role as an essential service. Please raise your hand, those that feel that it is. And those that feel that it is not. Okay, I see one in opposition and the rest that, did I read that right? Okay, so we're going to move on to the next one, food. Director Schmidt.
Mr. Chairman, as we all recognize, food is an essential benefit, no matter who we are, vulnerable or otherwise. But this is really more of a discussion about the system that supports vulnerable adults or those who are at risk in food access. And in conversations with our caseworkers in what they need when there's an emergent situation, food is essential, but it's not the biggest issue that they face. There are community resources, there are state resources that are allocated that make food accessible. I think you could probably argue if that food is healthy or if that food provides all the necessary nutrition. That I think is a different debate, but in terms of food access, the systems as they exist do fairly well in terms of emergent situations or temporary situations. And then the department also offers programs for ongoing, in addition to a food insecurity system through pantries, through food banks that then also make food available. So it is essential, but in terms of the state role, the state already has a role through a few of its programs. But when our staff are encountering situations with vulnerable adults, accessing food, whether it be through SNAP or whether it be through senior citizen centers who offer Meals on Wheels or some sort of delivery, it doesn't appear to be as big of a problem.
Questions or
Mr. Chairman.
comments? Please, Representative Summers.
Mr. Chairman, thank you. You know, we were, you on the Appropriations Committee were developing the budget last year. And I got a call from one of the guys that helps run one of our senior centers here in Sublette County. And he started talking about, you know, adults that were having a really hard time affording a meal. And I think the trade-off was, you know, do you buy food? Do you buy electricity? You know, do you pay your taxes? And so I think, and the reason I'm throwing all of those in there, I think one thing we don't look at, I'm not saying I agree that we don't have an expanded role in food, but I'm not sure that we take a holistic look at the adult with on a lower, very fixed low income, and how they're able to handle kind of the ombudsman idea, really, or how are they able to handle all of these expenses, and where are their holes in the system, where their individual holes, and that goes maybe to case management, but I think food plugs into that, right? Maybe people aren't gonna clamor for food if they know they have to fund these other things that literally keep them in the home or keep them heated. And I was really taken aback. This is in a small community of mine, and you know, obviously that's one reason I pressed you all to replace, you know, to come back and restore the cuts to senior centers. But I do think there's an issue there. I think we're doing a pretty good job on food, but I don't know that it reaches out into all of the small communities. Does it get into LaBarge? Does it get into Big Piney? Does it get into the various little communities around Wyoming that may have a senior center, but that are very strapped for finances? So that's a question more than I would concur that I agree that maybe we don't need an expanded, but I don't know that we understand it as well as we think we do.
Thank you, Representative Summers. Further comments? Director Schmidt.
Thank you, Mr. Chairman, and thank you, Mr. Speaker, for those comments. I do think it's appropriate to include right now what is happening with some of the ARPA funding that the department received in order to do an assessment of the food delivery system for people who are food insecure. And those recommendations have come back with, I think, some really innovative ideas about how we can expand capacity, looking closer at growers and producers and connecting them with local pantries so that we're using local resources more effectively in order to provide food to vulnerable people. That assessment's available on our website. It is lengthy, but I do think it has some pretty good ideas for local communities to explore and how they could develop more capacity to provide and supply that food system. It will take some startup money, which the legislature appropriated. So there will be grant funding that's going to be delivered to local entities to help with those, the building of that system. We recognize, the Department of Family Services recognizes that it's very fragile, which is why the conversation started many years ago. Certainly the First Lady has raised a lot of awareness about food insecurity, and I think the funding now can help support hopefully some long-term investments into stabilizing that system. So again, it's just another complement to this essential service, but I thought it was important that this committee know that there has been some work done in that space that's ready to be some bigger work.
Thank you.
Mr. Chairman.
Director Joe.
And just to that point, again, and please countermand me if giving you all of my notes and points is not helpful, but on the food issue, from my perspective, expanded role of the state would not be a recommendation for me, but leveraging the current role of the state to support the food security system and the work that's been done over the last 2 years to look at that and support community programs would absolutely be a continuing role, but not expanded from my point of view.
So Director Johansson, if I could follow up on that with a little more, ask you for a little more definition on that. So in my mind, in your agency, you have you have Division of Aging and oversees a lot of the programs that in funding that goes out to the Senior Citizen Center. So so are you saying that those are the local organizations that we're looking at? And is there value in looking at the program, the funding, the state general funds that go out to these local entities like senior centers, and evaluating the programs and maybe seeing if there's efficiency and expansion of services if we coordinate and define programs that could be funded that way? Is that where you're going with that?
Mr. Chairman, broader answer to your question is yes, I do think that's helpful. More specific answer to your question is it's a mixed bag. So the senior centers are absolutely part of, nutrition and food security for the populations that they serve, generally, but not all, but generally elderly who choose to, go enjoy congregate meals or home delivered meals through some of the programs that the senior centers provide. It's important to clarify that there are state funds that go there, but also a large mix of federal pass-through funds from the Older Americans Act and local matching funds. So the investment varies across communities. I think any senior center director or senior center staff would tell you their goal in their nutrition programs, whether in the center or delivered to the home, is to support anybody in need or wanting those types of services. But there is kind of a self-selection element there. There's not, it's not the only program that exists. So to Director Schmidt's point, in addition to senior centers, which have their programming missions and geographic reach, which is not, it's always limited, a senior center in Sublette County likely can't serve the entire county, very rural and frontier areas through congregate or home delivered meals, through other community organizations, nonprofit, the food security system that Director Schmidt can speak to better than I can. I think there's certainly roles and functions there that are outside of just the senior center. So it kind of a mixed bag, Mr. Chairman. But again, going back to my point, I think there are structures, programs, funding, both from the state and other sources that generate food systems in communities that can continue to be leveraged without an expanded role of the state.
Thank you. Any other questions? So we're going to vote on food, not as an expanded role, but as an essential service. Those of you that feel that that's an appropriate essential service, raise your hand. And those of you who feel that it's not an essential service, raise your hands. So Albert, I'm seeing you as a no, and I didn't get a vote from Eric.
So, Mr. Chairman, can you hear me
Yes,
okay?
I can.
Mr. Chairman, I didn't quite understand the way you called that. And so my vote would be, yes, I think the state has a role in providing food as an essential service. Do we have a role now to expand? Should we expand that role? My vote is no to expand that role.
So I'll try and say, and that's what I was trying to convey, that providing food is an essential service, but not in an expanded role.
I would agree with that statement. So
Okay.
then I guess I'm an aye.
Okay.
And
Thanks,
Mr.
and
Chairman,
thanks, Eric.
if I may, because I think I started this whole mess with this question being state role or expanded state role. We're happy to take the lead, work with Director Schmidt and her staff by the next meeting, and maybe with LSO from the notes of this to further define that of
Yeah.
what the task force's preferences were. I do think it's important to differentiate current role that's ongoing or an expanded role. But I think that would be helpful to take this table and maybe expand it a little bit for how this discussion has gone.
Thank you, Director Shannon.
Mr. Chairman, very similar to our speaker and Director Johansson, I would ask for more clarification. This is a subject that both privately and professionally is very dear to my heart. With that being said, however, are we voting to keep the essential services we have now or expand it? I would be opposed to the expansion, but keeping the current service.
No, and so the thought here is that food is an essential, that the state has a role here. And we see it currently with some of the programs that we already have in existence, SNAP and TANF, and we see it in the funding that goes out to senior citizens. That exists. We're saying that in this overall realm of food, there is a role for the state to help provide food through whatever program, whether that comes through federally or with state general funds, to help provide that, but not to expand what we currently have, but to further refine and define. Senator Barlow, please.
Thank you, Mr. Chairman. So this harkens back to me to a little bit to the behavioral health redesign and priority populations. And so maybe that's another way to frame this, is within the context of these different services and existing programs, is there a way to prioritize the vulnerable population within those programs in some meaningful way? So that's just a way I'm trying to frame it for myself. Thank you.
And I agree. I agree with that logic there, Senator Barlow. So staff, if we kind of give you some direction there on how you frame that for our minutes and to help them move forward. Okay, thank you. Let's go to medical care. Director Schmidt.
Mr. Chairman, I think we, recognize medical care as an essential service. And this one, I'm actually going to pass over to my colleague, Director Johansson.
Director Johansson.
Not being subtle this morning. That's nice. This is a
Is
big,
she ever?
a big one. With medical care, again, this is very similar to the discussion we've been having or will have on all of these items. Through the Department of Health and also through non-Department of Health, private insurance means coverage options are available. Again, what we're talking about is vulnerable adults, either suspected or confirmed through Adult Protective Services cases, as a category of the population that we're identifying, where in those cases that Director Schmidt's staff investigate, these are the categories that come up as leading to vulnerable adult cases. And in this case, access to or coverage for medical care, primary care, et cetera. This is a little bit of a tricky one for me, in that I think leveraging the coverage options both through the state and federal government, whether it's Medicaid for those who qualify, or private insurance subsidies through the marketplace for those who are under the age of 65, don't qualify for Medicare, et cetera, is absolutely a continuing and current role. There's both state and non-state entities that navigate and can help navigate folks to those coverage options. The real limiting factor comes when can you get appointments? Are you near primary care? Do you have a primary care doctor? And this will dovetail with transportation a bit. But the way I thought about this, Mr. Chairman and members of the task force, is not dissimilar from some of the automatic eligibility categories we have through the Medicaid program, which again is a health insurance product provided by the state and federal government. For our Title 14 DFS adolescents, where if you are in the custody of the state through one of those cases, you automatically qualify for Medicaid services. This is an option I think the task force would have in front of it as we look at the definition of vulnerable adults and those that are confirmed as being abused, neglected, inability to provide self-care, et cetera, where a Medicaid eligibility pathway could be there. Now that comes with an expanded program there and an appropriation, which is a lengthy and detailed discussion of what that looks like. In lieu of that, an expanded coverage option that would provide a pay source. I want to be clear, it would be a pay source for care. It doesn't solve the problem of distance or provider density in certain communities, et cetera, but a payer being part of that mix can influence one's ability to access care. That is certainly an option. In lieu of that, I think it would be similar to our discussion about the food system, that we have programs in place. We can better promote or make individuals aware, and through DFS and Department of Health, case manage and navigate to those coverage sources if that's what's lacking. And that would be my recommendation here in lieu of an expanded coverage in our Medicaid program.
So to make it, if I can, to make sure I understand it, we're saying not to, this would be to help find access to and resources to take care of primary care for those that have been identified as a vulnerable adult.
Mr. Chairman, that's right. So again, kind of bifurcated for me, that when a vulnerable adult case is being investigated and there are issues that might need to be handled on an emergency basis, but through that investigation, investigating staff determine there's medical needs that aren't being met, either because there's no coverage, no connection to local or regional providers. Again, dovetailing with some of the other categories like transportation can be a part of this issue. What those medical care gaps are can vary. My point here and my recommendation, similar to the previous discussion, is we do have programs, coverages, eligibilities, both state and non-state, that can provide access to healthcare coverage. Doesn't solve the problem of access to a provider, but again, it's part of that equation. And in lieu of another option to expand for this particular identified population of a vulnerable adult, in lieu of a new coverage option, as I'm suggesting in Wyoming Medicaid, then leveraging those existing resources, navigation techniques to find private or eligibility for public insurance like Medicaid, like the waivers, et cetera, which we can always do and should do more of. In lieu of a new coverage option, my recommendation would be that the state's role here is maintained at where it is.
Mr. Chairman,
Questions, comments?
Mr. Chairman.
Please, Director Schmidt.
And I think to add a little bit of narrative to Director Johansson's point about in lieu of, we do encounter vulnerable adults, whether they're elderly or young, that do not meet Medicaid eligibility. And so I'm saying it a little bit differently. I think what the director's trying to say is we could expand the populations that Medicaid currently serves to include these folks, or in lieu of that, do better at coordination, do better at trying to identify. But there is a reality that there are people that we serve that just will not qualify. And I think those are the folks that really create a lot of questions in the community about so what, how do we do this, et cetera. So I'm not advocating for an expansion, but I do think it's important to know that there is a population that really does fall through the cracks when it comes to looking at Medicaid as a medical insurance provider. Whether that there's an expansion of the state in other ways, I don't know. That is a bigger policy conversation. And certainly the director and I could look at that as we work through a lot of these issues and come back to the task force with a little bit more of specifics. Or we just really first try to think more concretely about how services are delivered across the systems, look for improvements there, and then do an assessment.
Mr. Chairman,
Director
if I
Johansson.
can add to that, I just want to be clear for the task force, and you all know this, but the Department of Health outside of our direct care facilities or field offices in public health, nursing, et cetera, does not, through the programs we're talking about, provide care directly outside of our role in facilities or community field services. So when we're talking about these programs, it's really who is the eligible population and who do we pay, essentially reimburse providers for their care. That's where Medicaid comes into play. But this, for the state's role of providing, to be clear, providing medical care directly to this population, strong recommendation that should not be an expanded role, but consideration of either leveraging existing coverages, like we've talked about before, or programs that are already in existence with the current state role being maintained, versus an expanded coverage group, which would mean vulnerable adults, like we did with the behavioral health redesign, are automatically priority populations, or in this case, a new coverage group. I'm not making that recommendation, just presenting it to the task force as it is an option that the state retains to make a coverage group in Medicaid that is specific.
Questions? So I have one, Director Schmidt, is I think it, at least in my mind, is reasonable to think that you could have somebody that's a vulnerable adult because of a medical condition, hasn't been to the doctor, hasn't. So we provide, we help them through that. They get well. Then are they no longer a vulnerable adult, or how is that part of the whole conversation? Right? And so as we look at this, I think there's some consideration that it's not a permanent ongoing, that these are medical services why they've been identified as a vulnerable adult. Correct? Director Schmidt?
Mr. Chairman, you're correct. And with elderly specifically, they're not going to get younger. So there may be a medical issue that we can help resolve at that time, but that doesn't always mean that that underlying medical issue goes away. It means that we've addressed it, the immediacy of it at that time. So there may be some where ongoing support is necessary. For example, if you have somebody with diabetes who isn't taking their insulin, and that puts them in a situation where they're an emergent, they are vulnerable, there's no self-care. We can step in, help get that back on track. But at the end of the day, somebody still needs to help them if they can't themselves take their insulin every day. So in this population, the emergency may be over, but the need for ongoing support may not. And so that's a medical care issue, but I'm not sure that's directly related to medical care. That's more about perhaps case management, or even, the last on the list, which is going to be a tricky conversation, is that someone who cares, that someone who is stopping by, seeing if they did take their insulin that day, because it's not a medical issue until they don't.
Okay. Looking at our online, any questions? Eric, please.
Thank you, Mr. Chairman. So would the good director either just outline briefly how it's being accomplished now? obviously it's being done at some level now, this healthcare. And if the question is, do we continue doing what we're doing, or do we have to have an expanded role? I think that's what your question is going to be later, Mr. Chairman, I assume. So how is it being handled now? Through what program would it be handled now? Thank you.
Well, and so I'm going to, Steph, and I'm going to Director Johansson, I'm going to point that at you with a little more in there. So if we have it now, where are the gaps and what is the gaps we're trying to fill? Because we're trying to resolve a problem, and if the program exists, then walk us through how we get there.
Mr. Chairman, I'll defer to Director Schmidt for detail on specific cases that, again, between now and the next meeting, maybe we could flesh out some of these gaps more quantitatively. Generally, with whether we're talking vulnerable adult populations or populations that, you know, communities are trying to help and maybe state systems or programs have not been involved, but they're being looked into. On the medical care side, for me, if it's not direct, if it's not in a state facility or in a you know, public health office that has very limited population health services like immunizations, things of that nature, then we're generally talking about where is access breaking down to coverage, to programs. And the resources I was mentioning before can absolutely be submitting an application to Medicaid, and DFS field staff do that all the time, help a client do that. Will this client be eligible for Wyoming Medicaid in one of our categories, which just as a refresher, in Wyoming Medicaid, you cannot just be low income and qualify. You must meet a categorical condition, you know, age, blind, disabled, some of these other categories. And as Director Schmidt pointed out, you do have individuals under the age of 65 that, depending on their income or assets, do not qualify for Medicaid and do not qualify for private insurance subsidies under the Affordable Care Act marketplace. So there's a potential, probably a small volume gap there of folks that would not qualify for a reasonable, you know, affordable health insurance product. And we could look at targeting that population. Again, I think it would be relatively small in this vulnerable adult discussion because we're really carving that pyramid pretty, slicing it up pretty small. But outside of that, I think the resources that are available when an investigation happens, and maybe there has been no access to medical care and there's wound care issues, or to Director Schmidt's point, growing effects of diabetes or hypertension, for example, then I think those processes start of how do we get this person into care, get some care now in the community, address the immediate issue, but then on an ongoing basis, do we need to help this person navigate to a private insurance product or a Medicaid application, or for those over 65, make sure that Medicare is being leveraged. I think that can be a current and maintained role of the state. But from my view, Chairman Larson, that's typically how I think it would be encountered on the medical care issue, before considering in certain parts of the state where medical care might be needed and the provider or the entity that would provide that care is far away, and that dovetails into transportation and case management.
And so Director Johansson, so as I hear you, the important component of this is while they have access to this resource existing, or however we do that, while they're considered a vulnerable adult. Once that is resolved, there may still be needs, but there's a need to move them to a different program and to take them out of this. We're not trying to expand this into this growing, ongoing population that is now no longer considered a vulnerable adult.
Mr. Chairman, I would totally agree with that, and frame it in a way that you have an agency in the Department of Family Services working and assisting on vulnerable adult cases. In my mind, this would not be the medical care of the vulnerable adult becomes the responsibility of the Department of Family Services time in memoriam. No, I think the emergent and immediate needs, and I think Director Schmidt and her staff would agree, are trying to be addressed in the moment with, for lack of a better term, some sort of transition or discharge plan, Department of Health term, but to ongoing supports if necessary and if desired by the person. Again, we're not talking about civil commitment populations. These are folks with autonomy who make their own decisions. So often it's encouragement of, this program exists. Would you like to apply or enroll, et cetera, et cetera. But I think your framing, Chairman Larson, of the long-term needs, that to me becomes part of the systems that we already have, albeit limited, but whether public or private resources for medical care coverage would ideally be leveraged as the individual hopefully has their needs met on an emergency basis and then transitions to some ongoing supports.
So I'd like to try and frame the question now that we're going to vote on for medical care is to address the medical needs that someone who has been identified as a vulnerable adult, to help them become with an exit strategy in mind for those services, meaning that they're no longer vulnerable. Doesn't mean that the condition goes away, but the services through as a vulnerable adult and then emerge into an existing program. So medical services as they're identified as a vulnerable adult until they can be transitioned into another program.
Mr. Chairman.
Is how we would, yes, Representative Summers.
So, Mr. Chairman, really, it's kind of a bit like the housing thing, right? We're looking at short-term medical needs until they can transition into some other program. Is that accurate?
It is. It
And
is.
Mr. Chairman, my question for Director Schmidt would be just her thoughts on how that, short-term, immediate or emergent medical care need gets met. Are we talking, again, from Department of Health perspective, we often think in terms of coverage or pay sources. From a field office or caseworker perspective, it's what's needed right now, literally, figuring out how to get somebody to a medical appointment or get that care delivered. So I think that would help kind of illuminate this conversation of what we would be talking about in that role. Short of that, my thinking on the medical care item here is that there isn't an expanded role because we have those coverage options that can be transitioned into when those issues are identified. But before making that statement final, I'd love to hear from the DFS perspective of what is needed on the field level when those medical care issues come to the forefront of an APS case.
Director Schmidt.
Mr. Chairman, and thank you, Director Johansson. I think the position that the Department of Family Services finds itself in is that it's the default. So we are making statements about the role of DFS as it pertains to emergency temporary services. However, when it's time to transition some of those adults into a system where, as Director Johansson, where they're getting their needs met, sometimes that does not exist. And then DFS then continues to case manage those cases in an ongoing way, which then takes away from that responsibility of emergent immediate help. And I think that's that's kind of the crux of the problem that we've been trying to solve, is in this area of nothing else where the state is the safety net. It's becoming a larger safety net to meet the needs of people who are going to continue to need some level of service. And I think that's the question that we're trying to piece out here, service by service, is then what is that role? In terms of medical care, to Speaker Summers' point, it gets caught up in that we lack access to medical care in many of our communities as it is. And then when you add or introduce vulnerability where transportation is a problem, self-neglect is a problem, then it's compounded. That frustration around access increases because the need is so immediate, in addition to other services necessary to help get that need met. So in terms of medical care, there are gaps. There are gaps in service populations. And when we encounter those gaps, if we encounter somebody who's 64 years old, does not then qualify for Medicaid, but still has a lot of self-neglect needs, what do we do? And in those situations, we do what we do in others. We really look hard to the community to see what they'll be able to provide, what they're willing to provide. We'll look to our budget to try to, piecemeal together services. But for some populations, and as Stefan mentioned, albeit small, there just isn't much. And it will be a continuation of trying to do our best around case management, trying to tie to whatever program is available if there isn't one. But until we can make that transition, we will continue to work with that adult.
So we're trying to, as we define, is this an essential service? We've not defined, we're looking for further light knowledge from our agencies on how we can provide that better. But what we're saying is that medical care is an essential service while somebody is diagnosed, or however whatever term we use, labeled as a vulnerable adult, until we can get them exited out of that condition or that situation and onto others. So we're trying, and we'll be providing medical care within the existing programs. Right. And that's what questions on, again, Representative Summers, I agree with you. It's much like housing, not to create a new program, but to do it within, to coordinate it within the existing programs, and with an exit strategy that when they're no longer considered a vulnerable adult, that we can move them to another program if that's even necessary. So with that in mind, those of you who feel that medical care is considered an essential service that warrants a state role, please raise your hand. And those who feel that it's not, raise your hand. Okay. Did we give you plenty of information to define that with? Okay. Let's go to transportation, Director Schmidt.
Transportation, again, Mr. Chairman, as some of these others, it's access to transportation, dependable transportation, reliable transportation, consistent transportation. And I know we're going to have another conversation about that today. But yes, we do encounter transportation issues, and that is a key to accessing food, medical services. That is one way where we can address other issues by providing just this one service. In regard to the role of the state, as an agency, we piecemeal those services. We can provide immediate emergent services, whether we provide the transportation ourselves or whether we procure that through some way, whether it be a taxi service or something. But this is another one of those long-term conversations about that will address the immediate need. But if that person doesn't have ongoing transportation, some of these other issues are going to be exacerbated.
Exacerbated, or we see them reoccurring.
Correct.
So we get them help, then we stop taking, kind of like the patient-centered medical home issue that we've had, right? And so how do we make sure transportation then is closely tied again to case management? You need to go to your doctor, you need to do this. Well, that's fine, but how do I get there? And then, so what we're saying is, what are the resources that we have looking within local? And again, I'll just use senior centers as an example. We have some resources there. Some have some counties, like my county has a county transportation system, but how do we access existing transportation and enhance that for vulnerable adults? Am I saying that accurately?
Yes, Mr. Chairman, and I think then within that conversation is to where, how often, et cetera. And I think that is the crux of the issue, but I think that is a local conversation. So if transportation is needed in a small community to a larger community, because that's where the services are,
Farson to Rock Springs.
Farson to Rock Springs, then what is the coordination locally? Then that helps facilitate the transportation from Farson to Rock Springs. And I think that might be the conversation that the state can support, but it's very much a community conversation.
So then as an essential service in the state's role, we're saying the state's role is to help coordinate locally those transportation. Summarize that again in a way that to define what the state's role is.
Mr. Chairman, I see it similar to housing and medical care, that the state has a role, and the state does have a role currently by providing funding for different types of transportation services. However, what I don't know if we've done very well is recognizing what are the needs, and is the transportation matching up with the need? And then that's the local conversation. So to summarize, it really is, it's essential benefit. I would argue it's an essential benefit, but I don't believe at this point the state needs an expanded role. It's more of coordinating locally.
And to define what essential transportation is.
Mr. Chairman,
Please.
and just to add to that, and getting some good information in real time from our Medicaid waiver administrator, there are things with transportation currently for a segment of this population that we do well. And part of that is how you bundle it, how you pay for it, how it's offered through, for example, the developmental disability waivers, which have pretty good transportation needs met, according to the information I'm getting and we've seen in our national surveys. That's not a standalone service like it is in the Medicaid state plan, non-emergency medical transportation, which has a mileage rate, et cetera, and take up and utilization is very, very low. It's hard to scale providers and provider enrollment in that kind of model. So we're looking at, I mentioned the DD waiver. We have our long-term care or community choices waiver that we've talked about as well, looking at doing a similar rate structure for transportation that bundles those with, companion services, adult daycare, where it's not just someone taking you and dropping you off at an appointment, but providing, supervision and that type of care where not only is the rate structure better, but there's additional services and assistance being provided versus, a taxi or something to be dropped off at a medical appointment. You go down from there, and I think you have community models, which Director Schmidt was alluding to, some provided by senior centers, which have transportation networks within the town or within the region and offer certain types of services, transportation services through their fleets. And I think all of these things could be looked at and potentially tweaked over time to better address the vulnerable adult population. But it doesn't strike me as a need for an expanded role of the state when we do have these options. Again, being very clear that with the developmental disability waivers, the community choices waiver, and these programs, not everybody is eligible. So those same limitations will be encountered by family services caseworkers when transportation needs to be identified, but maybe these eligibilities aren't in place. And again, I think that speaks back to the role of the state supporting or managing community infrastructure and networks that could be leveraged as well. So again, my thinking here is not an expanded role, but continue to improve and tweak the current transportation related services and programming that the state has for the vulnerable adult population. Thank you.
So then the vote on this is transportation is an essential service with the state's role not to expand, but to improve and make more available within the existing system that we have for the vulnerable adult population. Am I
Mr.
saying that?
Chairman.
Please, Representative Summers.
Mr. Chairman, I understand we're kind of voting on this now, but there's also a presentation coming up. And the one thing I liked the little piece of conversation I liked in that next presentation was, do we have any expanded role in expanding who maybe is eligible to receive money to do these services, right? So, we know we have these drivers that go around and do this, but is there a way for volunteers to get, more access to be able to get some money to do this driving, or family or friends or whatever? Is there a way we can expand that role? And so the reason I'm reluctant, I agree that we provide this stuff. I'm not necessarily saying we have an expanded role, but I think there's a conversation coming up just a little later in presentations, I believe, that at least the way I read it, maybe there is an expanded role. I didn't maybe understand it correctly, or if it's even feasible. But if there's a way we can get volunteers and families and friends a little money to do some of this, where they pay, that pays for their gas, that sort of thing, I think there's some real benefit in that, particularly in these smaller communities. And I realize this is not, where you got to go to a doctor appointment, but maybe it's just where you got to go get some food. I just think that would be a real benefit.
Thank you. And I don't think that this, as this proposal or this, as we're stating this, would exclude that, but we're saying that within the system we currently have as to how do we make that more available to people to be able to do as you are suggesting, Representative Summers. And then if we, outside of this, we're saying this is the essential and this is the state's role at this time. If you want to expand the state's role as we move forward, I think that that's a conversation that we're certainly willing to have. So those of you, as we've
Mr. Chairman?
yes,
Very briefly to address Speaker Summers' points, which I think are very well taken. That to me would be an expanded role. And I think it's a good point that a new broader, program that the state would design or finance in some way, maybe in partnership with communities, to give neighbors, volunteers, friends, loved ones an incentive to do that. Not within these specific programs or eligibility categories we have in Medicaid or Department of Health or what have you, would definitely be an expanded role. And I think it's a good point. That's not something that I moved forward favorably on in my notes or recommendations, but I think it's an absolutely fair discussion of adding to the, the state's role in providing transportation. Maybe not directly, but through those incentives.
And Mr. Chairman.
please.
And Mr. Chairman, I don't know yet. I don't have enough information to understand whether I think, what are the costs? What's the reality? All of those things that, you appropriators have to deal with. I think it's worth investigating, certainly, what an expanded role might be to provide some gas, for example, to people to get around. I don't know if it's possible. I don't know if it makes sense, but I think it's something worth investigating. So should we do an expanded role? I'm not sure, but should we investigate it? I think absolutely.
So let me try and rephrase this vote here, that we would, transportation would be within the programs that currently exist to better coordinate to make transportation more accessible to those who are vulnerable, with direction to investigate expanding the ability to provide transportation through reimbursement to those who are being the transporters. That makes sense? Those of you that can support that, raise your hand. And those who do not feel that the state's rolled in, raise your hand. Okay, we good on that? Case management, which is an important one, probably the most important one. Director Schmidt.
Mr. Chairman, thank you. And case management and someone who cares could blend a little bit, but to make the distinction for conversation today, when we say case management under this proposed essential service, it's a professional service, meaning somebody is getting paid to do the work. And currently, case management services are very dependent on the population, the qualification or the eligibility of the population. So for example, the department provides case management to those who are vulnerable. We are investigating, we are assessing. However, in the absence of other types of case management, oftentimes, we provide ongoing case management, even though that vulnerability has been addressed. And we provide it because without it, then there's risk that it will turn into an emergency again. So we're in this loop of we're addressing the issue, but in the absence of being able to transition, again, for medical care, transportation, whatever those are, then the potential for that person to re-enter an emergent situation is very real. So we then just provide the case management so that we can avert a crisis.
So is there some thought in that you would provide case manage? So it seems to me that there's this case management that APS, your agency, provides initially once they determine that that individual is a vulnerable adult. And we're trying to say that the state has a role. To that point, that's already in there or in statute and in that direction. But then is there a need for ongoing case management after they've received those emergent services, case management services, to determine whether they're a vulnerable adult or not? So once your agency through case management has determined that they're a vulnerable adult, then is there a role to continue for a period of time with additional case management? And what that time frame is, I guess, is up for discussion. And then it would be determined if there is a need for long-term case management in another existing program. Is that fair? And so it would expand. This would expand the state's role on a time limited, meaning for a period of months, and we'd look for you to come back with us with a suggestion on that either then those case management services stop or that then they're shifted to another program. Questions?
Mr. Chairman.
Please.
And I'm not sure it's in this case management piece, but it seems like it's left out. And that is the issue of guardianships and helping somebody through the courts and all of that. I think it was certainly in the literature I read, leading up to this meeting, it was talked about and identified as a fairly high priority. We're trying to fund it through ARPA. I don't see it necessarily on this list unless it is in case management, but it's really not case management. But I guess my question to the director is, where does guardianship fit in this matrix that we've created here, this table 1?
And so if I could add on to that question, so is when you go in to identify someone as a vulnerable adult, if memory serves me correct, you may refer them to Guardianship of Wyoming, but would you then through rule, as you define what the role of guardianship of case management is, include that component of guardianship in there? Because in my mind, Representative Summers, that is where this conversation, and I agree that it's an important one, but this is where I feel that lays. But Director Schmidt, if you could confirm that, please.
So, Mr. Chairman and Mr. Speaker, where guardianship shows up is under the category of someone who cares. What we see for someone who cares is that long-term support, that those people that are going to help that adult who may be vulnerable, that needs someone to advocate for them. And that's what guardianships are. It's a legal status that says there's someone that can make the decisions on behalf of that individual. So when we talk about case management, the case management function is to connect, to recognize first that that person may need a guardian, and then to connect them with a potential guardian, whether that be through the Wyoming Guardianship Corporation or whether that be a private individual who is willing to support in a long-time relationship, support that adult, that vulnerable adult. There are some states that provide their own guardianship. I don't know if I would advocate for that. I think the state role in that concept, it is a big expansion. I also don't believe that the department nor our caseworkers should serve as guardians. However, there are state models that do allow for that. What I would say here is that then the guardianships, which I think is an important conversation, coming under someone who cares, but it's the connection, the identification of that guardianship, that's the role of the case manager.
That clarify it, Albert? Okay, thank you. Any other questions on case management? And so we're voting on this as an essential service and saying that there's an expansion of the state role to, once that the agency has identified it, that they may be referred for a period of time to a case manager until the conditions of their vulnerability have been addressed and have been resolved, or can be moved on to another case management service. Those of you that can support that proposal, raise your hand. And those who disagree. That makes sense, folks? Okay, so someone who cares, that's helpful. So can we just say guardians? So Director Schmidt, if you can go with that.
Thank you, Mr. Chairman. So someone who cares, and we struggled with naming this benefit, because this is very much where volunteers come in, philanthropy comes in, service organizations, community organizations. And it's those individuals who will assist that adult after we've addressed the vulnerability issues to maintain the conditions that will allow them to either stay in their home or continue to be safe. And so that someone who cares, to your point, Mr. Speaker, could be that volunteer who is transporting somebody from one place to another, whether it be for groceries or medical care. But recognizing that there is a system that works currently to provide those services, but it is very ad hoc. It's dependent very much on local relationships between that individual and between the community's willingness to provide that support. And when I say community, I'm also meaning the individuals within the community. It's not just a given organization, but it's overall, are the churches involved? Are philanthropic organizations, volunteer organizations involved, organizations, nonprofits whose mission is to serve these populations, in addition to senior citizen centers. And I believe that that is a system that we probably tap into the most. When DFS gets involved, we are looking for someone who cares. We are looking for, whether it be a guardian, a family member, somebody, or a system in the case of the waivers, or a system to step in and take responsibility to assist or to support, make decisions on behalf of the adult. We don't think that that's the role of the state.
Mr. Chairman.
Director Johansson.
I support everything Director Schmidt said, and her and I have talked about this briefly, and I'm sure our staffs and our agencies have as well. One recommendation I would make to flush out either between now and the next meeting or as this, these policy recommendations unfold is looking at, guardianship, and that discussion is absolutely necessary, but it is sort of an ultimate outcome legally where we've seen success in some of our programs, especially in our waiver programs for supported decision-making models, which could be, replicated or used in the vulnerable adult protective services cases. And I'm a bit over my skis, so folks who work in this field and my staff or in DFS would know better than I, but I do think it merits investigation of this. Someone who cares, as Director Schmidt mentioned, is not solely around guardianships or conservatorships or things of that nature. It's absolutely a need and a gap we have in Wyoming. But I think there are models that we could look at for vulnerable adult cases, specifically for this population, where the case management that's leveraged uses those supported decision-making type functions that we've used in our waiver programs that, again, are pretty successful. We look at our data and see our participants on the waivers having that supported decision-making, and it doesn't always include, guardianships, but just something for us as agencies and maybe to visit about and bring back to the task force as alternative options within these two categories.
Mr.
Director
Chairman.
Schmidt. Director Schmidt.
And Mr. Chairman, I do think I need to be clear about this because there's guardianships and then someone who cares. And I do see a role of the state in guardianships. It is a legal process that requires legal minds to be able to first get through the court process and then to provide that ongoing guardianship service. So there is a role for the state in providing the funding for that service. However, I also think that there's a role of community to help find people who care, who maybe would be willing to take that responsibility on themselves without support of the state. So this is a both and in some respects, but in terms of guardianships, but I do see a strong role for community in terms of finding that person who cares, and family, very much family as well.
So I think maybe we're getting a little tangled up in the definition or the responsibilities behind a guardian. Right. So I think what we've heard heretofore is that there's a need for guardians to help them through in protecting assets, protecting their rights. But that might be different than a looser definition of guardian within the community to make sure that they get to the doctor's appointment or that they go to the grocery store, that they're this kind of guardian. And I think in my mind, I want to just say that guardian is that we want to use in this task force as the legal one to help them preserve their rights, defend their rights, protect their assets, help them through the legal challenges that may come when they're incapacitated mentally and that sort of thing. So is my question then to the two of you, is that guardianship does that, as I've defined it, does that then become a separate category than someone who cares?
Mr. Chairman, I think you could have both within this category, like we had in some of the others, where on housing, there's immediate emergent needs and then sort of a long-term ongoing. I think similar carving of this one is necessary, where again, guardianship is absolutely necessary, and there in cases and there are gaps there. We know that. But at the same time, what folks might refer to colloquially as, guardian services aren't, at that tip top of the legal definition. But again, someone who's invested in the case, someone who's helping an individual support their decision-making, make good decisions, navigate them through certain micro and macro things. I think both of those would be included here. And I can certainly see a role of the state and potentially expanded role of the state in developing better legal guardianship services for these cases. And then on the other side of that, with supported decision-making or alternatives prior to guardianship, looking at leveraging existing models in a better way, before or even if guardianship is not necessary to support vulnerable adults in these decisions
In the community.
in the community.
Right. And so I think what we've heard again previously is that we have some agreements with guardianships, like at the state hospital or the Life Resource Center for those individuals, but we've used some ARPA dollars on this vulnerable adult side to help get this, but that has been a gap in that. And so we find these vulnerable adults, and then the question to your agency is, well, they need a guardian just to help them through this court system, and you're having to figure that out. And so this would be an expansion for the legal guardianship role in this, find someone who cares, and then a coordination of local resources for the less specific definition of guardian to help them within the community. Right?
Yes, Mr. Chairman, I see that correctly. I see it as you see it. I think when we talk about someone who cares, though, there's homemaker services, which is a purchase service through senior citizen centers, et cetera, that kind of fit into this category as well. Someone who goes into the home and checks and maybe helps them clean or do laundry, some of those activities of daily living that for not some support may end up in a skilled nursing facility or higher level of care. So that someone of cares isn't just people or, volunteer. There is also a service delivery line that's involved here that currently exists. And so leveraging that better as well.
Okay. So Speaker Summers, does that help you see where we're bringing guardianship in? And I see your hand up. You'd like to further
Mr.
comment,
Chairman.
please?
Yeah, Mr. Chairman, thank you. So, I had a question, and that is, I totally agree with what Director Johansson said. That's what I view as, hopefully the guardianship is much like the other things we talked about, which is short term. My question is, the ARPA dollars, when I looked at the matrix that was provided, the ARPA dollars were both, DFS and Department of Health, different guardianship, different guardianships. But what I'm curious from the two directors is, what exactly did we spend our ARPA dollars on? And what was it for? Obviously it's short term because, it's only a 2-year program. I mean, it's really till 2026, and then the ARPA dollars run out. But I'm curious, I would like to hear what exactly the ARPA dollars were used on as it relates to guardianship, and how did they determine who received those guardianships? Or was it just giving to a corporation and then they made those decisions? So I would like to understand a little bit more about what the agencies did with the ARPA dollars. And that helps me understand maybe what I think our role.
Thank you, Speaker Summers, and I'll have Director Schmidt go to that. I think we had a little bit of that conversation when you were stuck in the airport last time when we were in Kimmer, but Director Schmidt, and maybe in some public comment, we can have guardianship talk about that a little bit. So Director Schmidt.
Mr. Chairman, Speaker Summers. So guardianship is a legal designation, and it's a service we purchase. So if the way that we used the dollars was some given to the Guardianship Corporation to serve people that they're serving. Also, when the department encounters somebody who needs a guardianship, we could use those dollars to buy that service from Wyoming Guardianship Corporation. So in large part, those guardianship dollars went to the Wyoming Guardianship Corporation because they are the service provider for that service. So we pay for the legal upfront work and then also the ongoing guardianship services that are provided on behalf of this organization for adults. So the Guardianship Corporation hires people to then serve as legal guardians for vulnerable adults, but it is a purchased ongoing service. It's not a one-time purchase.
So when the ARPA dollars run out, will your agency still have commitments then to Guardian for those service ongoing for the people that you've contracted with?
Mr. Chairman, yes, we will have ongoing expenses related.
And had you previously, prior to ARPA, been able to do that at the level you're currently doing it?
Mr. Chairman, no. Prior to ARPA, we were not.
That was one of the gaps that
Yep.
we've had. And so Speaker Summers, if I'm getting this right, you're correct. It's time limited on the ARPA dollars, but the commitment to the agency for ongoing funding of those services does not end at 2026. We're going to have to figure that out.
Mr. Chairman,
Please.
if I could, Mr. Chairman, what I understand what a guardianship is, but what I didn't understand, and maybe I still don't, is how did you choose the individuals that you put into the program? And I think that's where our expanded role is what population are we choosing to put into that? And for what length of time do we want to be involved? I think that's the two questions I want to hear a little more about. And I apologize that you probably went over all of this at the last meeting.
It's fine. We're glad the questions are being asked. So Director Schmidt.
Mr. Chairman and Speaker Summers, I'm going to look a little bit to my staff to help me out with this. But when it comes to identifying when we encounter a vulnerable adult and there isn't somebody, a parent, that can help them make those decisions, one of the first things we do is look for family. Look for people who they know, family who may then be able to step in and provide that support and help them make decisions and to kind of take over those decisions like financial decisions, et cetera. If we can't find anyone and it's clear that that adult cannot make decisions in their best interests, then we're going to look to the Wyoming Guardianship Corporation to provide that service. So it's not necessarily a selection deliberately. It's going through all of the options first. And once we exhaust those options, then we look to the Wyoming Guardianship Corporation. In my experience, and I'll defer to the director of the Guardianship Corporation, in my experience, that is a lifetime commitment. So this isn't a service where someone at some point doesn't need it anymore. This is lifetime. And so that service will be purchased until that person is deceased. And that's how then a slot opens up, unfortunately. But so there's capacity by the guardianship to provide these services. We pay them for it based on the person. However, when that person passes away, then that frees up their capacity to serve another person. Does that help answer the question?
Yes, it does, Mr. Chairman. Thank you. The one question I would have is, okay, so there's no slots available. There's nobody out there that can do a guardianship. And then maybe this question is then for the courts. So how do the courts handle that? If there's nobody available, but there's still this individual who has rights in a court but is unable to, fend for themselves, then do the courts step in with money, or how does the courts then handle it?
Ms. Butler, do you know the answer?
Mr. Chairman and Speaker Summers, so the courts don't have money to pay the guardians. Essentially what happens is if there is a petition for a guardianship or conservatorship, the court will appoint a guardian, and then the guardianship corporation or whoever will have to perform those services without the compensation potentially that DFS provides, unless, and Director Schmidt can jump in here, unless there is funding that comes from DFS or another agency to pay for those services. So the courts don't have a budget to do that, but they will appoint someone, and then the funding comes from somewhere else. And I cannot tell you where that funding comes from.
A bit of bullying, I would maybe suggest. Okay.
Chairman, yes.
All right.
Thank you.
Thank you.
Appreciate
Good
that.
discussion. Good discussion. So as we contemplate someone who cares as an essential service in the state role, we're looking really as the state's role into expanding the services for guardianships and then to coordinate locally and help local resources better coordinate for those the lesser definition of guardianship to help in locally and within the community. Those of you that feel that the state has a role in this and this is a state an essential service, would you raise your hand? And those who feel contrary to that, raise their hand. Well, that didn't take long. So folks, I guess I think we're ready to take a break, and I know that we went over, but this is a huge policy decision as we get ready to move forward in future conversations. It's what is the state, what's our policy going to be as we do this? And so I appreciate the questions. I think it was a very, very good conversation. Before we take a break, I would just ask the task force members if there is a service that you feel that we have left out that should be included. Good, thank you. Mr. Chairman, what I'd like to do is go ahead and take a 15-minute break. We'll come back and we'll get into the discussion with Mr. Laycock on transportation and our dementia directive. Then we'll take public comment on this collectively at that time. So let's take a little break. Thank you, everyone, for giving us a little time out there. We like to welcome Mr. Laycock with AARP, and if you folks would identify yourselves, and we look forward to this conversation, the ongoing conversation on transportation, and maybe after you've heard what we talked about here on the vulnerable adults can help us kind of understand some possible solutions and certainly underline the challenges that your constituents and the people you serve are feeling. Thank you. So Mr. Tom, if you would, please.
Thank you, Mr. Chairman, and good morning, committee. I'm Tom Laycock with AARP Wyoming. We're a membership organization for Wyomingites age 50 and over. I want to thank the committee for its work on its list this morning of proposed essential services for vulnerable adults. I want to offer AARP Wyoming support for that list and offer the talents and perspectives of the Subcommittee on Older Adult Transportation of the Governor's Healthcare Task Force as you determine how we can offer vulnerable adults transportation services. Today, I've got a few experts available for your questions around what makes transportation a big part of aging in the community, and offer a reminder of the buckets of transportation funding that the state uses. I know during our last meeting, we had some technical issues, and I want to make sure everyone was aware of how we fund transportation and where we might see some impact. While I do have a basic understanding of older adult transportation and around the policy side, the fact of the matter is I haven't actually transported any older adults since my parents were in town last month. So to that front, I want to make sure that you have the opportunity to speak to a few members of our Older Adult Transportation Subcommittee who are true boots on the ground in this effort. To that front, I'm joined today by Linda Cockett, who's the Executive Director at the Goshen County Senior Friendship Center. Despite its name, the Friendship Center is actually 5 different senior centers, serving the communities of Torrington, Fort Laramie, Lingle, Yoder, and LaGrange. This organization serves around 1,200 rides to older adults in Goshen County each month for everything from medical appointments to grocery shopping, primarily using 5311 funding, which we'll talk about in a little bit. Cockett offers a tremendous perspective of a transportation provider in an area of the state that is somewhat isolated, but serves smaller communities. I know there's been a question of how do we make sure that we've got services available for everyone from Cheyenne to Farson, and this is a great perspective here. Cockett's been the director of the Goshen County Senior Friendship Center for the past 8 years, and this year served as president of the Wyoming Senior Services Association. So we'll hear a little more from Linda as we discuss 5311 funding. AJ Mock joins us online until 11 o'clock when he's got a meeting with the county commissioners, and will also be at your disposal to discuss his experience acting as a transportation provider using both 5311 and Community Choices waiver funds. They serve around 1,200 clients at the Buffalo Senior Center. Mock's perspective is a little bit different from Cockett due to Buffalo's geography, which allows for multiple trips each week to Sheridan and Gillette, in addition to serving folks who are in town. Mock told me roughly 80% of those out-of-town rides are medical in nature, and we'll discuss why that's important in a little bit. He's been the director at the Buffalo Senior Center for the last 13 years and is really an advocate for looking into ways that perhaps regionalization may benefit the state as well as its citizens. With us today to answer your questions about 5310 funding, which we'll talk about in just a couple of minutes, is Amy Burns. She's the executive director for Wyoming Independent Living and has been a very active member in our subcommittee. Wyoming Independent Living focuses on all aspects of life that impact the ability for older adults as well as disabled persons to remain in their homes. Transportation is something Wyoming Independent Living does well by using existing transportation offerings in communities while augmenting those efforts by finding funding for volunteer rides or use of local transit networks. Wyoming Independent Living has worked on the transportation issue in Wyoming since 1985. And Burns has been at Wyoming Independent Living for the last 16 years. Wyoming Independent Living is one of 2 organizations using 5310 funding in the state of Wyoming. So we'll move on. We do have a few slides to show you today. We want to make sure that we offer a little bit of an overview, and those slides do exist in the back of the packet. I apologize for giving you a packet that is basically Dunder Mifflin's dream. There's a whole lot of stuff here, but feel free to look along with us. Mr. Chairman, by 2030, nearly 1 in 5 Americans will be 65 and older. Here in the state of Wyoming, that number is much closer to 1 in 4 citizens, which already are 65 and over. In slide 3, we simply use this as a visual representation to illustrate where those 95,000 citizens over the age of 65 in Wyoming live. This data comes to us from the American Community Survey produced by the U.S. Census Bureau and compiled by the Healthy Wyoming Aging Data Report released last summer. You each have a copy of the data report in your packet. Slide 4 shows us in the data a little different way, that it's a heat map showing that the state's county population by age, specifically the percentage of county population of those aged 65 and over. As we move to slide 5, I'll remind you that we have 95,000 Wyomingites aged 65 and over, and the ACS tells us roughly 10% of those self-reported difficulty in living independently. Page 5 of your slide deck will show you by county where those folks reside. As the committee, once again, as we've been trying to illustrate the fact that the need for services is statewide. Specific to transportation, slide 6 is a reminder of the 2021 survey of APS caseworkers, which was the genesis of our work at the Older Adult Transportation Subcommittee of the Governor's Healthcare Task Force. On the left, it was the question of the top needs for vulnerable adults as seen through the eyes of APS caseworkers. On the right, this comes from the Senior Centers and Older Adult Perspective Systems perspective from the State Plan on Aging through the Department of Health. As you can see, once again, transportation is a challenge through the eyes of both. I did get an email, in fact, yesterday, that Jane Carlson at APS is refreshing the APS caseworker perspective. So we may even have some data on that sooner than later. On our next slide, we know that transportation plays a big part in our healthcare system's viability. While prevention numbers are notoriously difficult to prove, this study by the Florida State University suggested up to an 11-to-1 payback on money invested by the state when it comes to getting disadvantaged Floridians care through medical mobility programs. While I'm not a statistician myself, the study was referenced in the National Academies of Science, Engineering, and Medicine's guidebook and research plan to help communities improve transportation of healthcare services. The FSU study is actually 41 pages long. I did not give you all of that in your packet, but some of the relevant material as well as methodology is in the packet should you want to dig into that a little deeper. Slide 8 is a new one. You haven't seen this one before, but it was referenced a little bit earlier in that conversation around how far do people have to go to actually get to a physician. AARP recently commissioned a survey on the attitudes of Wyomingites around emergency medical services in the state. I'll have those results for you in the coming months. This slide seemed very appropriate to our conversation today. We asked 1,003 Wyomingites age 18 and over how far they live from various medical services. As you hear from our experts, specialty care is a big component of transportation services in Wyoming and costs quite a bit, bringing its own challenges. As you'll see on the bottom of that page, 35% of those surveyed this summer said they live 45 minutes or further from specialty care. So now let's do a quick review of how the state of Wyoming pays for transportation in the state. The first one being 5310 funding. These, once again, are our federal funds that are based off a state share of population for developmental disabilities and individuals. As mentioned, we have Amy Burns with us from Wyoming Independent Living, and she has been fantastic in explaining kind of how this particular program works. In essence, they're taking federal funds and helping folks to pay for rides, either using vouchers to pay for existing transit through senior centers or community transit, as well as folks who are quote unquote volunteer drivers who can pick up to 36 cents per mile for driving. Generally speaking, we find that when someone enters this program and self-identifies as being disabled, which has a disability to keep them from driving, they also come in with somebody who, whether it be a friend, a neighbor, someone who can help them actually provide some of that on-demand transportation. So that said, we have Amy here if there's any questions that you have specific to 5310 funding. And Amy, is there anything that I missed that you'd like to bring up in terms of what you guys do really well?
No, thank you so much, Tom. I don't think there was anything missed. I know that this is directly relevant to the conversation earlier about needing to recruit more volunteers and private drivers, since public transit is quite limited. We are thankful for that opportunity to reimburse them. Obviously, it doesn't match the federal reimbursement rate, but it does at least offset the cost of gas alone, which obviously has been increasing in recent years. But I'd be happy to entertain any questions.
So Amy, can you, this Representative Larson, could you just help me understand the difference? This money's coming into YDOT. We got 5310 and 5311. It appears that the 5310 comes in as to helping those with disabilities. I'm not quite sure what the 5311 is intended for, but if you can just help me understand the differences, and it sounds like we're maxed out on both of those.
Yeah, so my understanding of the difference, 5311 is geared towards statewide rural transportation, where 5310 focuses specifically on older adults and those with disabilities. And yes, I would say we're maxed with our current capacity with the funding that's been allotted.
Thank you.
Mr. Chairman, as it relates to 5311 funding, you are correct. We are maxed out. On that funding, I think I've asked Sarah Ellis at YDOT about 16 different scenarios, and it keeps coming back to no, unfortunately, we're maxed out. So the 5311 funding, that really comes down to our fixed route stuff, our senior center, things, community transport such as University of Wyoming, some of your local buses, things along those lines. But really, the 12 million that the state gets, a lot of that does go to senior centers. And that's why I wanted to make sure to have Linda here, as well as AJ as someone who actually uses that money and kind of what's that look like to them.
So do you know, Tom or Linda, once those allocations have been made, then does it just repeat the same funding source each year? If the federal money is the same, do they just keep those coming in year after year? Is there a reappropriation on that annually? And then who's making the decisions on where this federal fund goes? Is that YDOT? Can you help me with that?
Thank you, Mr. Chairman. So it is looked at annually. We look at ridership. We look at whether those funds have been appropriated. If they haven't used all their funds, their budget may be cut for the following year. Those considerations. So the initial look is from YDOT, and then they bring that to the YTrans board, which is a statewide board of transportation providers, and we approve or disapprove their recommendations.
Very good. Thank you.
One of the reasons that Linda came with me today is obviously she is on the board at YTrans. She's someone who actually uses these funds, but she understands probably better than I do some of the challenges that come along with those funds. So we wanted to make sure she had the opportunity to speak with you and you pick her brain as well.
So one of the things that comes to all transportation providers is that we have to meet a certain match for those funds. So any funding that comes for administration of the program, overhead costs, utilities, things like that, we have to meet a 20% match for those fundings. Any maintenance considerations for our vehicles or our building also requires a 20% match. And then operating expenses. So our fuel, our vehicles, our drivers, those kinds of expenses, we have to meet a 43.44% match for those funds. And for small providers, that is a huge barrier because a lot of times those small entities can't meet that kind of match from counties, cities, local fundraising efforts. And so it becomes a barrier on how much service they can provide because they can't meet that match necessarily.
Mr. Chairman,
Go ahead, Representative Summers.
Mr. Chairman, and maybe you're going to get into it. I went through the slide deck, but I can't quite remember. So do we have any idea how much is being left on the table? In other words, or who is being, who's not being able to fulfill their match or not do what they want to get done? Do we have any idea kind of what you more specifics on what you just said?
Linda?
Thank you, Mr. Chairman and Speaker Summers. I do not have those. I think YDOT would be able to provide that more clarification for that question. I do know that because of the amount of red tape and paperwork that that YDOT requires, a lot of senior centers are looking at, is it truly worth it to apply for these funds? Because there's so much involved in that reporting process, as well as the match.
So staff, could we ask you to reach out to YDOT and just give us a summary on who those grants go out to and how much is not utilized, just a little, and distribute that back to the task force, please? So do they have requirements on what percentage of the overall grant can be used for administration, what can be used for operation and maintenance, facilities? Can you help us with that a little bit?
Absolutely, Mr. Chairman. So administration costs cannot go over 40% of the entire grant. Then maintenance and operating, that is pretty much left to the individual organization on how they want to split that up.
Your administration that would include payroll for administrators, but wouldn't include your drivers, right?
Correct.
That just seems high. So I was a little surprised that you could use up to 40. So what percent do they normally use for administration?
I can only speak for my agency. Ours is about at 35%, because we have myself as a director. We also have a finance person who has to do all of the reporting for that grant. We have somebody who does our computer that has to track all the rides, that sort of thing. And then all of our insurance and all of that comes out of administration as well.
Thank you.
And Mr. Chairman, we do have the list of grantees from last year and how much they got, who they were. I'm happy to share that with you.
Please.
Mr. Chairman?
That's an easy fund. I'm not sure we're missing out on funds per se in terms of being able to access more in the federal funding. I think it's more a matter of we're probably not being able to deliver as many rides as we'd like because of the.
Yeah, and I think that's the assumption all of us are making, just trying to Representative Summers' point, is there anybody that, because they're not able to make their local match, that they're turning back any of their state funds, and what percentage of that? Just trying to get a feel of that. If you've got that, maybe you can get that to staff. Representative Summers, please.
Mr. Chairman, thank you. One thing when we ask YDOT is, obviously we hope all of these requirements are federal requirements and not state requirements, so I think that's one of the questions I would ask YDOT on this program. And then the fact that even 35% of the program is administrative seems incredibly high. But if you have to stand up a program from square one, I guess maybe that's the case. And so that's my question back to Amy is, I guess is it Amy? Whoever's at the table. It's probably not Amy because I'm seeing Amy on the screen. So
Did I get it
Mr.
right?
Chairman, Linda. Oh, Amy
Linda,
is.
Linda.
Yes.
So my question back to Linda is this administrative cost, is this only administering this program, or does this also administer other transportation programs that you have? And so is this just a way to fund administration for a larger piece of pie, or is this just what it costs to administer this program? That's my question.
Linda.
So thank you, Speaker Summers and Mr. Chairman. We use 5311 funding only for transportation, so it's just for that. We do use some 3B funding from the Department of Health to also help fund transportation. But the 5311 administrative costs is strictly for transportation.
Follow up, Mr. Chairman.
Please.
Mr. Chairman, so I just want to be clear. And I think the answer is yes. The administrators of this program also administer some other funds for transportation, which is a good thing. I mean, I'm trying to help you out here in a way, because if it's 35% to administer a federal program, then my goodness, it's almost, I can understand why people are turning it away, because that's far too much money going into administration. But if it's allowing you to seek other transportation funds and administer them, then it has some real value. Obviously, you believe it has value, but am I right that you are using it to help administer other funds that are coming in, and it's not just administration of these 5311 funds?
Yeah, so the 3B funds that we receive, we also use for some administration costs. The majority, at least of our 3B funds, goes for operating and maintenance.
But majority is only 51%. So of your 3B funds, what percentage of those is going to administration?
So it is far less. It's probably around 8%. It's difficult to separate that because those 3B funds also support all the activities in our center.
This is through aging.
Yes.
And Mr. Chairman, 3B is actually on the next page. If you've got,
Let's go there, Mr. Wilcox.
I wondered if you wanted to offer the mic quick to AJ, since he's got that 11 o'clock with the county commissioners, to see if he had anything that he wanted to add before you had to move on. I'm not sure if he's still with us or not.
That'd be fine. AJ, please.
Hello, and
Mr.
I
Mock.
do apologize. Hello, can you hear me okay, Mr. Chairman?
We can hear you. Thank you. Thanks for being here. Sorry that we went over. It's not your fault.
I do apologize, I have to leave, but yeah, I think Linda summed it up very, very concisely. Yeah, I don't really have anything else to add. And just want to reiterate just the regulatory requirements that WYDOT, and it's not necessarily WYDOT, but the federal government does require us to go through. So it does take a lot of time and a lot of effort in order to complete our requirements for that. So thank you.
So what would you do if you, so how much do you receive from the federal, how much of the federal dollars do you receive through WYDOT?
So Mr. Chairman, the actual number or the percentage?
No, the actual number. My follow-up question would be, so if it's so difficult, if you let it go back, what does that do? If you just say we're not going to play this anymore because it's too administratively burdensome, what does that do to you?
As far as a dollar amount, Mr. Chairman, you know, we ask for around $120,000 per year to offer our services to our community. But we do provide a service to our community that is, I believe, necessary and vital. You know, without the federal funding, we wouldn't be able to offer any services to some of our most vulnerable individuals in our community. And so I don't know if we would ever give it up per se. You know, just the requirements though are heavy, and so that requires more people and more time to meet those requirements. So, but yeah, I don't think we would ever give the transportation up.
So has there been any conversation with WYDOT? How do we streamline the burden that comes with the reporting? Is it just is it volume of information? Is it the types of information? Is there, do you, as you're filling it out, does any of it seem unnecessary? Or does it all seem unnecessary?
Mr. Chairman, you know, I think they're being directed by the federal government, the FTA. And so I don't know if YDOT necessarily has a choice in what they can require providers to do and what not to do.
Okay, thank you. That's helpful for me.
You're welcome.
Any other questions for Mr. Malk from the task force? Mr. Malk, thank you. But again, we apologize. We know you've got a busy schedule too.
All right, I appreciate it. Thank you.
Tom?
Mr. Chairman, the next thing we thought we'd bring up is Title III-B services. Not a tremendously large spend, with the bulk of it actually coming from federal funds as well as matching. Title III-B is run within our Department of Health. It's an Older Americans Act program. Jeff Clark administers that. He's a Torrington trailblazer. I'm surprised he's not here today. Generally the tallest guy wearing a blue shirt in the room. But he has never had a question. I've never had a question that he hasn't been able to answer immediately. So a tremendous resource there too. That did provide 84,000 one-way rides in the state of Wyoming last year, and once again, largely through senior center transports. And so if you've got questions about how that differs from 5311 on a practical matter, that's kind of why we had AJ and Linda with us as well.
So Director Johansson, maybe you can help me there. It looks like that's about a 50-50 match. 242 local. And then we provide, no, federal funds 242,000, local is 276, and general funds is 19,000.
Yeah, Mr. Chairman, the general funds in this particular area are relatively low as a percentage. But we do pass through the Older Americans Act funding, federal funding.
And it requires about a 50% match, maybe a little more.
Mr. Chairman, I'd have to check into the actual requirements. Obviously, you can see in the funding, it appears that way, but I can't remember off the top of my head what the local match requirements are.
Thank you. Questions, anyone?
The next page, Mr. Chairman, is the last one that we really had. And once again, this is just a quick overview on Medicaid transportation options. Remember, there are two different types, the Medicaid state plan, which is medical only, and then the community choices waiver, which is for those who are working, those who have a nursing home level of need and a Medicaid level of financial need, but are being treated through home services as opposed to nursing home care. That is where Representative Summers, you were asking about helping with volunteers or someone, you know, get some gas money, get paid as it relates to trips, you know, in town or somewhere close. And the community choices waiver is the waiver that has actually been working on that self-directed care change, which would allow, you know, friends, neighbors, folks like that to go ahead and give rides and get a little gas money for it. Any questions on that piece? I think those would be the buckets that we use largely as a state for transportation. There are other, of course, local donations, things along those lines.
I guess I have a question on your state plan one. You searched 45 individuals, 793 rides at $7,000, and then it's 6,800 rides for the $39,000. And I guess so the Medicaid state plan, the community choice waiver isn't choice waiver on the state plan. It's separate from the plan.
Mr. Chairman, similar to our discussion this morning, so transportation through Medicaid programs is provided in a variety of different contexts. And so with state plan, you can see relatively low utilization that has to do with, you know, provider density network and rates, what's attractive, what isn't. just for non-emergency medical transportation. Through the community choices waiver, kind of a similar, low volume that you see there. What I was mentioning before is through our supports and comprehensive waiver on the developmental disability side, we've incorporated transportation into other services, which we're looking to model in the next year or two into community choices waiver so that it's a bit more of a bundle for support where friends, family, neighbors could not just be paid gas and mileage reimbursement for taking someone to an appointment, but be part of that service array that makes it a bit more attractive and also provides better service.
Thank you.
Mr. Chairman, that's a game changer if we could make it happen.
Yeah.
Truly.
So, and then the process for that, where can you, is that in process that, or is that the plan to start the process? Where are we at on?
Mr. Chairman, I'll check with staff on that after this meeting. I know the discussions internally in the Department of Health are in process to make those changes. We always plan conservatively on our timelines with changes to waivers because that involves the federal government. But I'm more than happy to brief back the task force on when we think something like that could be implemented. But I would plan for 1 to 2 years. Obviously, things can be accelerated, but just being conservative.
Thank you.
Mr. Chairman, next page, and this is, we've got basically 2 pages left. Everything behind that is just reference from things that we had talked about previously. So recommendations of our older adult transportation subcommittee, these are the ones we made last time. Supporting that self-directed care options for CCW. I think what we've really found out is, as we've dug into this, is that there's really no one simple thing to do, right? You have to have the fixed route stuff, which is senior center stuff. You need some on-demand supplemental stuff for when people, unfortunately, there are a number of transportation providers who do sometimes need 24 hours, 48 hours notice in order to get a ride booked, things along those lines, for example, even for, getting approval on a Medicaid CCW trip. So being able to have that mix really works well. And really that self-directed care option for community choices waiver really adds to that on-demand availability. The second thing we had talked about was increasing the Medicaid transportation rate. There is a rate study that's in process. And then once again, supporting some of those recommendations. As I mentioned earlier, there's no simple place, and this is where the rate study will come in, but there's not a real good place to figure out what anyone pays when it comes to other states pay when it comes to Medicaid transportation. But we have seen some US DOT data here and there where other states have been asked, what's your Medicaid rate? What's your waiver rate, 1915C rate? Suffice it to say, we're way below anything else that we've seen and quite a bit below. So that'll be important. And once again, that'll help providers such as Linda and AJ want to jump in on that because we've had some conversations around what that looks like. And other providers have told us, unfortunately, the juice isn't worth the squeeze at this point. Simplifying that process, and that's something that I think the Department of Health is always looking into. Studying rideshare and volunteer ride options. 211 did get money from United Way a couple of years ago to.
Tom, can I interrupt you there?
Please.
So the simplified Medicaid process, is that just getting somebody that's providing the rides? Is it the application process that's difficult or challenging? What part of that simplifying the Medicaid processes are we talking about?
Mr. Chairman, I'll be happy to answer what I know or have Linda jump in as well. But it appears a lot of the documentation that's required for actually getting payments through that process can be a little difficult.
So it's just submitting your invoice for payment that's a challenge. Is that correct, Linda?
I would also say there's quite a wait time for when somebody applies for Medicaid funding for that application to go through.
To be a provider?
Yes. Well, to be a provider, but for the client as well. For them to be approved to be a Medicare or Medicaid recipient.
Oh, okay. Yeah. Okay. Thank you.
Yeah. The other things I would bring up are studying rideshare and volunteer ride options.
I'm gonna come back. So I think we have like a 35-day payment requirement, something like that. Does that sound right, Stefan?
Mr. Chairman, happy to follow up offline. Provider enrollment, depending on the provider and their interest in serving, can be a barrier. I would say the improvements to our provider enrollment system recently are much more efficient, and we can talk through the ways to leverage that. For providers that are enrolled, our claims system now pays in minutes with allocations twice a week. So the system's efficient, but I think the front end work of deciding to become a provider, the things that are required for provider enrollment, things you have to attest to, likely what Linda's referring to. And we're certainly sensitive to those, which we agree with the bullet point on simplifying what we can.
Thank you. Tom, please.
Yeah, and Mr. Chairman, if you look at the 2 pages that have the boxes, these are also sort of process for what it looks like to become or get a ride. As on the state plan in red, and then in the black boxes are the ones that are community choices waiver. And so I've tried to simplify the process as it's been explained to me through Department of Health. But it can be a little bit, it's a bit of a, you know, it's not linear always in terms of process. And so it's something that, you know, could probably stand a revision or review. The other things we had mentioned are study rideshare and volunteer ride options. Speaker Summers had been asking about that. And it's a little too bad that we lost AJ. He's someone who, through most of these meetings, has said volunteer rideshare has to be a part of any solution that we have in the state. Once again, we get to that point where we get what we think are volunteers, and the first thing they say is, well, what about my liability? You know, and then the conversation kind of falls off a little bit. So we'll continue those conversations. And on the next slide, we'll talk about one of the things that we're actually talking about, and then considering regionalization. You know, AJ has been a big advocate of regionalization where possible, where you've got a Buffalo, a Gillette, a Sheridan, you know, 3 communities that are reasonably close. And can we do regionalization software by which we know that if I take someone to Sheridan for a procedure at the hospital, which has dynamite specialty care, is Sheridan's transit coming back down at any time, or do they have to wait a couple of days until I make my way back up? So those are some things that are sort of cooking in the, you know, in the back of our mind a little bit. Last page that I have for today, just things to consider. First and foremost, our subcommittee, as well as the state's providers, are here and happy to help with providing a statewide strategy. One thing that has been brought up is the question of, could the state help communities with local funding as it relates to 5311? I know of at least 2 states that do. Alaska and Kansas have in the past. And so it wouldn't be completely unprecedented by any stretch of the imagination. Once again, we bring up one size does not fit all. Make sure you've got fixed route, ride share, as well as the on-demand stuff. And that, of course, requires a diverse funding base. The last 2 things that I'll bring up, there are some pilots that are kind of out there. EMS pilot on August 6th. I'm having a conversation with CRMC. They've started Cheyenne Regional Medical Center. They've started 2 transportation pilots, one getting folks to and from appointments, medical appointments, and another that'll be sort of, I believe, sort of checking on some of their frequent flyers as far as EMS is concerned without taking the ambulance, the whole ambulance there, you know. So we'll get a bit of an update on that. That program just started last month, so we'll know a little more about it. Tomorrow, I think it's noon, which I'm not sure who put that appointment together, but we're seeing a little bit more in the way of rideshare companies that are interested in getting into medical transportation as well through Medicaid. So we've got a conversation with Lyft Medical in terms of talking about what it is they do and how they do it. They're in a number of other states right now. Maybe it's a thing, maybe it's not a thing, but we figured we'd at least listen in and see if that's something that has any impact. The last thing I thought I'd bring up as we talk about liability is we did have a conversation with Tori over at the state's local government liability pool. Because one thing that Linda's brought up, a number of her specialty appointments don't go to Cheyenne, they go to Scotts Bluff. And there is an impact insurance-wise as soon as you're transporting people outside of the state. Would you mind kind of expanding on that a little bit?
So we have to pay additional insurance anytime we cross state lines, and our insurance company only lets us do that for medical rides. So we end up charging $1 per mile for any medical ride, whether it's to Scotts Bluff or Cheyenne. We've also taken people down to Boulder and Loveland to those medical centers. That gets cost prohibitive for a lot of our seniors. However, I have to pay a driver that entire time that they're gone, and it could be an 8 or 10-hour day for them, depending on how many tests, how long the wait is to get in to see their doctor, that sort of thing. And then we have to pay the additional insurance on top of that, plus the gas, plus wear and tear on the vehicle. All of those things come into consideration.
And given the fact most of our population centers and specialty care tends to be out of state, this is something that has percolated up a little bit. And we have talked to state, local government liability pool just to see what would that look like? Is there anything we can do about that? So that said, that's everything that we have. We threw a lot of information at you. I apologize if it was a little bit of overload, but what can we help at? What are next steps that we can provide in terms of research, in terms of presentation to this committee?
Thank you, Tom. Members, any questions for Mr. Laycock? Or for Linda? Thank you. Thanks for both being there, and thanks for the last, this and in Kimmer. It was very helpful and helps us doing that. Mr. Chairman, we've got to make a little adjustment in our schedule to accommodate our K-12 mental health conversation. The folks that are here to speak on behalf of BAR have been very kind to join us here in person. They've got to catch their flights and will need to leave around noon. So what I'd like to do is move this conversation from the vulnerable adults, and I realize that we haven't taken public comment. We'll do that before we break for lunch. We'll do it on, probably will not get through all of the K-12 mental health here, but I want to shift gear and bring the conversation, Lachelle, if we could, Ms. Brand, if you wouldn't mind coming up, and let's shift gears over to the K-12 mental health services and the use of the BAR model, what that entails, and then perhaps Mr. Brown will be able to tie all of that in with how we would use that in coordination with BAR and the other stuff. So thank you folks for being with us. Sorry, it's my fault for going over. We've been working on this vulnerable adult stuff now for a couple of years, and those were some critical conversations that we needed to make. And but I do apologize. We respect your time and hope that we haven't cut you short.
Mr. Chairman, committee and task force members, I'm Lachelle Brandt, Deputy Policy Director in Governor Gordon's office, and I really appreciate the time on your agenda today to participate in the discussion regarding K-12 mental health. And I'm pleased to introduce you to Mr. Rob Metz and Ms. Beth Heimer. Mr. Metz is the Deputy Director of the BAR Center with 36 years of experience in Minnesota's public schools. He has served as a superintendent, high school principal, elementary principal, teacher, and coach. He retired as the superintendent of schools in the town where the original BAR High School was located. And as a high school principal, he witnessed firsthand how the BAR model can accelerate learning and create a safe, strength-based learning environment. Since 2018, he has helped scale the BAR model to 350 schools nationwide, achieving consistent positive results regardless of school type, size, or location. Ms. Beth Heimer is the Director of Schools for the BAR Center. She is a 25-year veteran educator who began her career as a classroom teacher and has since worked in administration and curriculum oversight. Is Mr. O'Mang with us as well? Okay. Also pleased to introduce Mr. Josh O'Mang, who is joining us virtually today. He is the principal of Detroit Lakes High School in Detroit Lakes, Minnesota. After serving as an administrator in the Twin Cities, he returned to his alma mater, where he is using the BAR model to make significant impacts. And I know we're short on time, but before turning it over to those three, I just wanted to briefly provide some context and background of why I'm here today. And that is, as Senator Baldwin pointed out earlier, the governor's commitment to mental health and suicide prevention. And in addition to that, in 2021, Governor Gordon appointed an advisory group that many of you, I'm sure, are familiar with, who conducted a statewide survey and community listening sessions across the state to gather feedback and make recommendations to improve our K-12 education system. The top recommendations from parents and students and educators was to shift from a one-size-fits-all model to a more student-centered learning approach. Equally urgent was the need to address student well-being and behavioral health comprehensively. And I'm pleased to say that 20 of our school districts are now participating this coming year in RIDE. This year, I've also had several opportunities to learn about the BAR model by speaking with state leaders, superintendents, principals, teachers, and students whose schools and lives have been transformed by it. I've been very impressed by the data and the impacts that I heard that it's having in this country. The BAR model is uniquely responsive to the recommendations provided to the governor by the RIDE Advisory Group. It offers a holistic approach that not only enhances academic outcomes, but also prioritizes the mental health and overall well-being of our students. I'm thrilled that 3 of our districts will be implementing the model this year, and I will let the Department of Education talk more about those efforts. And I will say it's been really great working closely with them over the past year or so on thinking about what is a good approach, a plan to align what services are in the state. And I think we have some good recommendations. I'm grateful for this time that you've allowed on your agenda to delve into the details of the BAR model and hear about the significant success and impact it's having in our schools. And the insights and experience shared by our esteemed guests will, I believe, provide valuable perspectives as you consider policy shifts and initiatives to support our schools in fostering student success. The governor's office is committed to working with this task force and the legislature in how do we best address our mental health in our K-12 schools. And with that, Mr. Chairman, I'd like to turn it over to Mr. Metz to begin their presentation.
Thank you, Lachelle. Thanks for that introduction. Mr. Metz, as you get ready to explain, and I'm sure you've had some conversations with Department of Ed and with Ms. Brandt, just bear in mind as we're trying to figure out how do we accomplish mental health in our K-12 model. And like the AWARE program that the Department of Education has put together in responding to mental health, but feel that there is a gap on preventing. And, you know, in my conversations with Lachelle and then back with the superintendent of public instruction, you know, we're hoping that this fills the gap in doing that so that we don't then have to create a mental health system in our K-12 model. So if you'd kind of bear that in mind and help us to understand and perhaps anticipate questions that we have as you present that'd be very helpful. And thank you for being here again. And we'll turn the time to you.
Chairman Larson and Baldwin, committee members, thank you for inviting us today. As mentioned, my name is Rob Metz. I'm the Deputy Director of the BAR Center, longtime educator from elementary teacher to superintendent. I started teaching in 2 schools that had less than 500 students K-12 and ended up being the superintendent of a fairly large suburban district. The highlight of my career, however, was being the high school principal of the first BAR school in the nation, where I saw firsthand how BAR helped our students and our teachers. We know that the governor's office, the Department of Education, and the legislature are very concerned about students' mental health. Thank you for seeing BAR as a strong partner who can help schools identify student needs early and engage families and community services in a proactive manner. It's truly an honor for us to be here. I'm here with Beth Heimer, and I'll ask Beth to do a quick introduction of herself.
Good morning, Chairman Larson, Chairman Baldwin, and task force members. As Rob mentioned, my name is Beth Heimer, and I am a 25-year veteran elementary educator, starting as a classroom teacher and working in administration and curriculum oversight. It's an honor to be here. This morning, we hope to do a brief reintroduction of the Building Assets Reducing Risk model. We will then hear directly from a school leader about the impacts BAR has had for his students, teachers, and overall school climate. Principal Josh Omeng will share how the BAR system helped teachers identify student mental health concerns and connect families with community resources to address these concerns.
BAR believes that students and teachers are incredibly talented. It's actually the system that's out of date. We all inherited the factory model, assembly line school system. Students move from grade to grade, from class to class, as if they're on an assembly line. The math teacher sees what happens in math. The science teacher notices something about the student in science. The soccer coach sees a completely different student during soccer practice. They all see their pieces, but no one is putting all the pieces together. BAR places a system in a school. For example, in a BAR school, these teachers would be meeting together, sharing all of their pieces with one another, discussing and putting together a picture of the entire student. Then they're able to see and intervene when incidences arise much quicker. And when they do come together to create strategies for students, they're much more likely to work. Next slide, please.
So BAR redesigned a school around two pillars, relationships and data. And when we're talking about relationships, we are referring to student-to-student relationships, staff-to-student relationships, and staff-to-staff relationships. And when we talk about data, we want to look at real-time quantitative data, but also qualitative data. We need to know what is happening academically in the classroom, but we also need to know what is happening outside of the classroom. What is being observed at recess? What's being observed in the lunchroom, on the athletic field, in between peer relationships? And we absolutely need to make sure that we're focusing on each student's strengths. What is working well for them and what are they interested in? I want to be really clear that we are not changing curriculum and we are not replacing staff. What we are doing is utilizing the resources that the community already has in place. We know this works because research has proven that this will work in all contexts, rural, urban, suburban, and have impacts for all students, but especially those furthest from opportunity. Next slide.
BAR is the most researched educational initiative ever, I believe. We have done 78 randomized control trials, all in 9th grade, which means that in 12 of those cases, half the 9th graders did BAR and half didn't. They were randomized by an outside evaluator, the American Institutes for Research. And after 1 year, AIR determined which side did better, the sides that worked under the BAR system or under this system as usual. In every case, the BAR students outperformed the non-BAR students. The other 66 studies were between school studies, where two like schools were compared. A coin was flipped. One school got BAR in 9th grade, the other didn't. And after 1 year, the outcomes were measured. And in every case, the students in the BAR school did better. Out of that research came 20 statistically significant outcomes, which you can see on the screen. 14 of them are student outcomes, but 6 of them are adult outcomes. And AIR has said that among all the initiatives that they've studied, BAR has the highest outcomes for teacher retention. It seems amazing sometimes that you could look at one change and see all these outcomes, but we hope by the end of this presentation, you'll see how that is possible.
Mr. Chairman.
Director Johansson.
I
please.
apologize for interrupting, Mr. Metz, but as a side note, we have a saying in my office, RCT, or it didn't happen, randomized control trial. So I reviewed a lot of the BAR data over the past several weeks, and the results are absolutely compelling. My question is, and you might address it later in the presentation, so feel free to punt. The academic achievement outcomes that were measured are there, they're real, they're extremely compelling, as I mentioned. Could you address, are things directly related to mental health? And that's kind of been the discussion with this task force around episodes, higher acuity, aggression, things like that are harder to measure. And I don't know if I'm making sense with the question, but what I really like about the model and the results that it shows are on the academic achievement side, which I think correlates to mental health. But specific to this task force's conversations, I didn't see anything in there about, observing or measuring mental health outcomes specifically. And it might not be the role, so I'm not suggesting that, but would be curious for your thoughts now.
We
or in
will,
the
we
presentation.
will get to that. Mr. Chairman, I apologize, Mr. Chairman, committee members, we will get to that. And more importantly, when the school testifies, they're going to be able to give some really good examples. Next slide, please. BAR works upstream. It's very proactive. In a BAR school, we are intentionally focusing on strengths, building supportive relationships, increasing student engagement, increasing the number of assets and protective factors that students have, and building higher expectations for students. As a byproduct of that, we get a lot of positive effects downstream. So BAR is very preventative. Next slide, please. BAR focuses on building assets. Assets are the good things that young people need to grow and develop. The more assets you have, the fewer risky behaviors you're going to participate in. It's like a teeter-totter. We are intentionally building assets, and as assets go up, risky behaviors go down. I describe BAR as an asset building machine. You can see that our outcomes identify that as supportive relationships go up, student engagement goes up, expectations and rigor go up. When that happens, our evidence shows that chronic absenteeism goes down, discipline incidences go down, substance abuse goes down, and suicide ideation and attempts go down. Hence the name BAR, building assets, reducing risks. Next slide, please. Some of our earliest data that came from the original school identified these two areas. In the original BAR school, thoughts of suicide among both boys and girls went down significantly more when compared to the state average. And suicide attempts went down significantly more, both for boys and girls, as compared to the state average. A quick story. There was a young lady in the school who was a very high achiever, straight A's, but she kept asking for more work and harder work and extra credit, even though she was getting straight A's. One of the BAR teachers brought that concern to a teacher meeting, and another teacher on the team said, "I'm also noticing she's losing weight, like something doesn't look right with her." A third teacher on the team said, "And she looks more withdrawn and inward. She's not sharing quite as much as she used to." They put all those pieces together, and one of the teachers said, "I think we should call home and just share what we are seeing with the family," which they did. That very week, the family took the young lady to a doctor. An eating disorder was diagnosed. She got treatment quickly, and she went on to recover. And as an adult, was very successful, graduated from law school, is a very successful attorney. I share that as an example of how these small pieces can come together. If teachers are given the right systems and structures to work in, they can do this kind of work on a regular basis. Next slide, please. This is a mediation model that AIR, the American Institutes for Research, the folks that did the evaluation of BAR, put together to really show how BAR works. And when I describe this as a former high school principal, I would say most schools in America, if they're trying to increase their math scores, they start on the right-hand side of this chart, and they change something in math. They change the math curriculum, the sequence of math courses, the math teacher. They've been trying this for years and get almost no success. BAR does it just the opposite. We start on the left-hand side of this chart. We teach the adults at the school how to use this new system. They believe they can make a difference. When that happens, they collaborate differently with one another. They use data differently, and they are able to build positive, intentional relationships with the students. When that happens, the students feel more supported. They know more is expected of them. They become more engaged. And no surprise to any of us, engaged students attend school more, get in trouble less, and that leads to academic outcomes. So the academic outcomes are just a byproduct.
Let's go to a question.
Yes.
Representative Summers.
Mr. Chairman, thank you. On the previous slide, because this task force is focusing on mental health. You have two schools, two schools, and one in Minnesota, one somewhere else, and St. Louis Park High School. So one shows positive change, and the other one does not show positive change. And so I'm just curious. I assume both of them had. Thoughts of suicide went down, but not in males in one, and then attempted suicides actually maybe went up a little bit in that one school. So I'm curious. I'm just a little curious about what are you trying to highlight with these two schools when one isn't showing change and one is showing change?
Mr. Mitz.
Mr. Summers, Mr. Chairman, the dark lines are the school that we're highlighting, the original Barr school. The blue dark line are the boys in that original school. The red dark line are the females in that original school. They're being compared to the state averages in the state of Minnesota. So the dark lines in both cases are decreasing, which are the students in that school.
That track with you, Albert?
Mr. Chairman,
The lines that aren't.
I look at lines going actually up. If you go to the attempted suicide in Minnesota males, that percentage actually rises. So I'm not, and females, it actually looks like it rises. So I must just not be understanding the.
I believe, and Mr. Mitz can correct me, but I believe the line that's going up is the state average. And the line going down are those students that participate in a Barr program.
Exactly.
And so the results of that, those students that participated with a Barr emphasis went down while the statewide average went up.
Gotcha. Thank you.
Thank you. Thank you, Mr. Mitz.
Yep, thank you. Next slide, please. I believe we covered this, but the way this works is a left to right, upstream to downstream approach, where the academic outcomes are just a byproduct of a new way of operating a school. Next slide, please.
So in a Barr school, there is a system and a structure for the teachers to know the students and what's happening in their classrooms academically, but also to have an awareness and discussions about what's happening outside of the classroom. Often kids with mental health issues are experiencing bullying. A therapeutic treatment can help a student deal with that harassment, but it's not going to help prevent it. The Barr system works on creating healthier overall culture based on relationships. And how we do this is by starting in the middle with activities for the teachers to do with the students facilitated in their classroom. And an example that I like to give of what that activity might look like is the classroom having a conversation about different adults in the student's life that have shown that child that they feel supported and they feel cared for. They then extend it to having the students identify an adult in the building that has shown them that they care for them and support them. They are then asked to write a thank you note to that adult and deliver it to them in the classroom. What we are coaching the teachers to look for is when that activity starts, is there a student who is asking for multiple thank you cards, signaling that they have multiple adults in the building that they are feeling supported and cared for? And on the other end, were there any students that had to sit there and work harder to try to identify who that adult in the building might be. That information is so critical for us as educators to understand who in our schools are feeling supported and who is feeling isolated. And with that information, it is critical that as educators, we are not holding on to that information for ourselves, but that we are sharing that with the larger school community so that we can then bring that information to our team of teachers, share our observations, and then authentically and intentionally figure out how are we going to make a connection with that student so that they also are feeling seen, supported, and cared for. For the students that are experiencing higher level needs and the teachers have utilized their strategies and are not seeing the progress that they're hoping for, they then refer those students to what we call our Community Connect team. And that Community Connect team are going to be stakeholders in the building, but also in the community that are going to make sure they are utilizing all of the different appropriate community resources for that intervention strategy. Early identification and referrals greatly come from the likelihood of risk behaviors or mental health concerns becoming the norm. So, what are the services that we provide? Every school will receive 2 days of implementation training prior to the start of their year. Subsequent years, they'll receive training on substance use prevention, effective communication, and how to do trauma-informed practices. We also assign every school a BAR coach, and that BAR coach is going to work with the school for the 3 years of implementation. We ask every school to identify a BAR coordinator, and that person is going to who takes the coaching and has those conversations with the coach. They will have weekly conversations over the course of the 3 year to make sure that they are understanding the implementation, creating action steps, and evaluating how it's going. That coach will also go on site for 4 times the first year and 3 times for year 2 and year 3. When they are there, they're going to observe the different BAR components. They're going to discuss with the administrator. They're going to discuss with the coordinator, and they're going to be available for the educators and just immerse themselves in that school community culture. They then are going to provide feedback for that school on what is going really well and what are some next areas of action steps for that implementation. We also provide professional learning communities for the BAR administrators and for the BAR coordinators so that we can network them across the country with other schools that are implementing to share best strategies and practices. We also have a variety of tools and resources that our schools will have access to. Next slide, please.
Such as, what are the tools and resources?
Fidelity forms, rubrics for teachers to use, the lessons that we talked about, spreadsheets that they can track the student data on to have comprehensive cohesion across the staff on what are we looking for, how are we measuring it, and how are we discussing it.
Thank you. Please continue.
To put into mental health terminology, BAR utilizes a system of meetings to identify student mental health concerns early and work with families and the community to identify resources needed to help that student. Whatever the structure of the school may be, whether it has an MTSS system in place or has in-school mental health resources available, BAR structures will ensure that the family can get connected to the in the community if they choose. The BAR approach to tiers prevention is efficient and effective.
So I'd like you to say that again. You said BARs will ensure that the families, say that again.
BAR structures will ensure families can get connected to the resources in the community if they choose.
How?
We will work with the school community to make sure that we are looking at what are the resources available and make sure that those community resources can then work in conjunction with the school, whether it be telehealth or actual practitioners within the community to connect them with services.
So Mr. Brown will have a follow-up conversation with that, please. Thank you.
Mr. Chairman.
I'm just, so just so you know, I'm trying, Albert, I'll get you, so I'm just trying to connect what we've got this AWARE program and we're trying, I'm just trying to make sure I connect. Albert, please.
Mr. Chairman, thank you. So ultimately, that's a great concept and it should work, but ultimately, if maybe parents don't do anything and that child still comes to school, some parents don't even, or some kids don't even hardly have parents. And so the child comes to school with a mental health emergency. What does your program do to deal with that? Because ultimately then a teacher or a counselor or an administrator has to deal with that child in real time. So tell me how your model addresses that.
Chairman Summers, Mr. Chairman, there certainly are those critical immediate needs that occur. I think what our next speaker will share as the principal in his school is that the number of those go dramatically down because you are catching things early and preventing so many of those things from occurring. You're always going to need the ability to respond to immediate needs, but there'll be fewer of them in a bar school.
And I think, Albert, and I'm looking over at Mr. Brown, is in the Project Aware, being able to identify, screen as we've been in then to refer. So I think in the situation that you brought up where somebody comes in and we need to have the capacity to screen and then refer, they're going to learn a lot of those skills through the BAR program, but the Project Aware program then helps them to understand how and where to stabilize and refer.
Yep. Yes, Mr. Chairman, that's accurate. That's how the Project Aware model overlays with the BAR model, is that identification, recognition, and referral leads to those community resources. So they supplement and feed off of each other.
Thank you. Mr. Mitz.
Mr. Chairman.
Please.
Mr. Chairman, and I totally agree with all of it. And I agree with, this pyramid we've seen several times now, and it's a good thing. If you start upstream, you win downstream, right? I mean, I think what you're trying to do is totally accurate. The point I'm trying to make is there are still going to be kids in crisis in schools with parents, and you have to deal with them. And the school has to deal with them, or you lose those kids. So there's no scenario where we lose a child where it's good. We improve, that's great. But ultimately, we don't want to lose children. And so I just want to make it clear that there's still going to be a role somewhere in the school to have to deal with children in crisis where there may not even be a parent in the background that cares. And that just exists. Thank you.
Yeah. I think that everybody on the task force would acknowledge that. So thank you.
Well, the best way to understand BAR and how it supports schools is to hear directly from a school leader. I am honored to introduce Josh Omang, principal of Detroit Lakes High School, a rural community in northwestern Minnesota. Detroit Lakes is located near the White Earth Reservation and has a significant percentage of Native American students. Josh grew up on this reservation and after serving as an administrator in the Twin Cities, has returned to become the principal of his old school, where he is using BAR to have huge impacts.
Okay, Mr. Omang, I hope I said your last name right. I'll call you Josh. I can get that part right.
You bet. Can you hear me? Can everyone hear me?
We can.
Okay. Mr. Chairman and members of the task force, my name, like they said, is Josh Omang. I am honored to be here to talk a little bit to you today about how BAR works in a school and to bring it to life. And some of the questions you've had, hopefully I can answer here in the next few minutes. Before I do that, I just want to give you an idea of what our school looks like. We're a rural school. We're in the northwestern part of the state. We serve about 860 students. About 20% or so of those students are Native American students from the reservation, the White Earth Reservation. And, you know, we do have a high percentage of economically disadvantaged as well. We're on the border of the Red River Valley and Lakes Country. So just to give you an idea, we're very much a community of haves and have-nots. So that's kind of who we are. So if you go to the next slide, I'll jump into trying to explain this better. This is a slide I often use when I talk to folks about BAR or try to explain how it works in a school, why it works, and why it is a program that is amazing. We're all well aware of the challenges that exist in education with kids, with everywhere. Mental health has been one that I've heard here today a lot. We also know that a lot of times our response to that is to create a new initiative, right? And so what you have then is you always have 20 or more initiatives in a school that you're trying to juggle and make sure that you're doing them right, and to make sure that you're trying to figure out, hey, do they actually work, right? I mean, there's all kinds of programs people design that are kind of like one-offs. And what I would say to you that's different about BAR, and why I use this slide, is that it brings all of those things under one umbrella, and it allows your staff to actually do all those things if you just use the BAR model. And that helps us not get overwhelmed. It helps us use data. It's more of a way of doing things. It teaches your staff how to identify these challenges early. So some questions about mental health and what would you do? I mean, we're at the front lines of this every day. Educators are, and that's the reality, right? And so if we can identify some of those little things and talk about them in a systematic way early, that helps us. That helps everybody. It helps us get kids help faster, so we don't need to, have all these crises all the time. So that's kind of how it works in a school. Last year, I had a veteran teacher of 34 years who testified to our legislative group that said, this is the first time in my entire career I feel like I'm not on an island, that I have a team behind me, that we actually can come up with solutions for kids and actually do something about these issues we see. So if you go to the next slide, I can give an example of how this works. This is a slide that we have for our attendance process. As you folks know, chronic absenteeism is a major concern in this country. It's been worse over the last few years. One thing that came out of us implementing the BAR system is creating these connections with the community and making that stuff more efficient. So this is our process for dealing with kids who are absent to school. And what ends up happening is we ended up spending a bunch of time with our county and totally revamping the entire system of how we dealt with that. And that was all came out of these community connect meetings that Beth had referenced earlier, where we invite those folks to the table who are resources. Again, I think we're all aware that we can't just continue to add mental health professionals or counselors. I mean, that's not wise anyway. So we need to really make sure we're leveraging the folks we do have access to. And so for us, that was meeting with our judges, our county attorneys, our social workers, getting them actually to come to our meetings. And now we have 3 social workers that totally changed their way of doing things, and they just show up to our meetings and we collaborate to get these kids help way faster than just the old method of, doing referrals and waiting until it's 15, 20 days, what have you. So that's an example of that. If you go to the next slide,
Before you go to that next slide on that absentee one, I would be interested to go back to the slide where you said about 16% of your students are Native American. Well, it says maybe closer to 25%. So if you just took that population, would you see the reduction of chronic absenteeism stay at those same percentages, or tell me what the effect just on that population alone has been?
I can show you the effect on our entire school, which I don't have that slide specifically for you today, but what I will say to you is the connections and they're just the way that this program has helped build connections across kids in our school has really improved our attendance for that group, and also referrals to our area learning center. So we have an area learning center here, and over time we had quite a high population of our native kids who were being referred to that area learning center because they weren't successful, and we have made a huge reduction in that in the last 4 years. So I could get the exact number to Rob for you. But I do have a slide that shows our 3-year average here, and how that's come down. So like this.
Yeah,
this
I'd really be interested if you could get me that on your Native American kids in my district. It's where the Wind River Reservation is at, and it's something that we've tried working with those districts. They have a high chronic absentee rate, higher than the state, and we're just, as we've had this conversation on BAR, we have high hopes that it can help reduce that. And I'm just curious on that particular population, if you've got data that shows anything on that. If you could give that to Robin, you can get it to Lachelle, and we could pass that on. I'd appreciate it. Thank you. Move on, please.
No problem. So here is the chart of our data for the last 3 years. This is pretty typical across the country. Like I said, lots of schools were 45% plus chronic absenteeism after the pandemic. So, then the question is, what do you do? And so a lot of the things, this is part of the reason why we went to BAR here, is because we needed something to do. You can't, punish your way back to better attendance. And so this has been awesome for us, but I also would say, I don't believe we could have had this growth if we didn't use this model, because it has actually leveraged our entire county and everybody around here into a team approach. And that works, when we do that, things do work and they work better. So if you go to the next slide, this is an example of kind of the mental health stuff that we've been talking about. This is an actual student from our school that was on our Community Connect group. They got to that 3rd level. They had a lot of concerns were coming up. We were working on trying to figure out what to do. And we got this student help, and their attendance, actually, this is a student who had missed over 60% of the school year as an 8th grader. And by the end of 9th grade, we had her attendance rate up to 60%. So we literally flipped it by identifying those things and getting her connected with some of these services that we already had, right? And then further, we use this with our staff too, to help train them, on here's the kind of kids we have, here's what to look for, here's what we did. So we also use it in that way too. If you go ahead to the next one, I believe I have some of the stuff here that relates to behavior and academics for our school. If you see those charts that say at risk, in our system, at risk means you are failing 3 classes or more. Why this is important to me is, whether it's mental health, chemical health, whatever, those are the root causes typically. These things are the symptoms. And so to me, if we're really good at identifying the symptoms school-wide, from our staff all the way up to our counselors and admin, we have a way better chance of actually making progress. Kind of the old way is just you get to the end of the school year, you add up your F list and whatever, and then you sometimes are like, oh man, that wasn't good, or we don't really know why. And that's what I would say about this is, this is real time. I mean, these meetings happen every week. So our staff is totally in tune to, you know, boy, this kid is misbehaving. I wonder what's going on. Or, man, you know, Josh suddenly is failing 3 classes. We need to talk to him. We need to right now, not wait until the end of the semester. So that's kind of some of the results. And then finally, if you go to the next one, you know, this was our second year of doing bar. And I am from this reservation here that services our school. My mom is a member of the tribe. I'm a descendant, first person in my family to go to college. And what I'll tell you is this is the first time we've ever had that group have a float in our homecoming parade. And I feel good about that, but actually, you know, as a student from this school, I'm kind of sad about that because there was a lot of years where, again, we didn't, you know, we would refer these kids to the ALC or just say, you know, whatever, it's someone else's job. And the reality of it is, if you go to the last slide, it is our job. You know, our kids deserve people that can inspire them. Here's 2 examples from my school of kids who were on our bar system, who are now, this kid on the right here with a company called BTD. It's a manufacturing company. He signed with BTD like kids sign for sports to go to a sports team. He signed into a career, and he was a kid again too. Some mental health issues, you know, and that, how did that bubble up here? It bubbled up by attendance. Same with our student here on the left. She became a CNA while she was in high school, saved $40,000 picking up all the shifts that nobody else wanted, and is now in nursing school at the University of North Dakota. So hopefully that helped to kind of illustrate what it looks like in a school, and certainly be happy to share or answer any questions that you may have.
Thank you, Mr. Omong. Any questions from the members of the task force? Great explanation and well done. Thank you for joining us.
Absolutely. Thank you.
Okay.
Next slide, please. This is our final slide, and then we can stop and answer questions. The couple things I would add is that as those teacher teams are meeting, taking all the individual pieces they know, putting them together to truly see the whole student and create strategies for that student. I would say in my experience as a high school principal, about 80% of the time, the interventions and strategies that they created were non-academic. There was something getting in the way of that student being successful in school. I always told people we could get them in the right class. We could put them in a IB, AP honors course, a regular course, or a support course. They were in the right course most of the time. There was a non-academic barrier that was interfering in their ability to be successful. And by knowing those students so much better and so much deeper, that team of adults was able to identify those barriers and remove them. And that's why this upstream to downstream approach works so much better. Thank you for your time today. We greatly appreciate it. We'd be happy to answer any of your questions.
Task force members? I think you've got a plane to catch. It's not cheap over 3 years. And we'll be having a conversation on that. That's
Mr. Chairman.
please, Representative Summers.
Mr. Chairman, when I reviewed their data, one thing and he brought up the AP that was really real positive is, it actually showed improvement in AP and dual and concurrent courses, and which is, you want to pull these kids up. So I think it's really interesting, and I know that there's some Wyoming schools that are going to test it, and I know that I think Kimmer's maybe going to test it, Teresa Chalk. And if you can get her to, you know, say that it's good, then I'm a believer. So, anything we can do to try things is a good thing, right?
Thank you. I agree. So, you know, I will just tell you that I come from a kind of a construction industry, and when I go buy a piece of equipment and they tell me the value of it, my question is, why is that yellow one much better than that green one? Right? And so a justification for the cost is something, you know, I wonder what committee I sit on. The justification for the is we see it. I see it here, and I appreciate that, and we understand, and we understand that we need to. Where I'm struggling is, I'm not able to track why it is what it is per school, based on population, based on what's the formula, and am I getting the same good deal as North Dakota's getting, or am I getting, you know? And so as you guys go back, I think one of the real challenges that we're going to face, and we heard what you're going to provide, you know, and two meetings a year for 3 years and some stuff like that, and then there's some ongoing costs. I think helping as we make recommendations and we figure out, and knowing that they're one-time costs, right?
Correct.
And then it should be self-perpetuating and be able to go. And I think that's all very positive. But why is that yellow one better than that green one? Okay.
Mr. Chairman, if I may. Because I had the luxury of being a high school principal and then the superintendent in that same district, I was able to learn a lot about costs. Our district saves significant, literally hundreds of thousands of dollars a year, every single year after we implemented BAR. And the reason for that is that the 9th grade failure rate dropped so dramatically, as you saw at Detroit Lakes High School. We were reteaching English 9 over again, Math 9 over again, Science 9 over again. We were having large summer schools that were expensive. We were sending kids off to alternative schools, as Principal Josh was saying, which is extremely expensive. 3 or 4 years later, that failure rate had dropped. We were not reteaching classes. Our summer school was a third as big. We were almost sending nobody to the alternative schools. I was signing checks for hundreds of thousands of dollars for all of these things that I didn't have to sign anymore. So the prevention model at the district level will definitely save them money. When there are fewer students getting suspended, fewer students getting expelled, all of those things cost money. And so by reducing those numbers, the recapturing of dollars at the district level is very evident. Also, to an earlier question, one of the biggest barriers to students taking AP, IB, advanced courses in high school is they fail 9th grade classes. So if you fail 2 or 3 9th grade classes, now you're in 10th grade and you have to retake those classes plus all your 10th grade classes, and you're not feeling very good about yourself. In our school, we went from a 40% failure rate, 40% of our 9th graders were failing 1 class or more. The lowest it got when I was there after implementing BAR was 12%. Well, now we had way more kids that we could approach leaving 9th grade, going into 10th grade and saying, Beth, I think you should be in AP US history instead of regular US history. You're talented, you can do this. So the numbers of AP and IB and honors courses at our high school just skyrocketed. That was a direct result of that 9th grade failure rate going down and having so many more students eligible to be in advanced courses. There were many talented students who would have never signed up for an AP or an IB course if they had failed a 9th grade course. But once they get over that hurdle, they can do it.
And I appreciate that your excavator can dig a ditch, but so can the other. But you're not telling me how you get there. Okay. And so I appreciate, and I really do, and I'm really quite excited. But as I look at the cost structure of it, I'm not understanding. There's got to be something there that helps me understand how you come up with the cost model that you come up with. And, and expect you, we expect you to make a living. I know that you give us the all-around cowboy good deal, but I still don't understand that. And I think that as we go in front of the committee that I'm a member of, and we try to sell this to our colleagues, we have to have a little bit of an understanding on that. And I'm not saying it's wrong. Please, I'm not, but I don't understand it.
Mr. Chairman, I can just add, and then I think Michelle may have something to add. The greatest percentage of our cost is the cost of the coach. So we assign a coach to each one of these schools. They physically visit the school 10 times during the 3 years that we are coaching them. We've learned through all this research that it really takes 3 years for a school to embed this new system so they can fully own it. And then we leave. So there's no tails. There's no ongoing costs. We're not adding any staff to the school. We're just retraining the school how to use this new system. And it's really the cost of the coach. They have weekly calls with the school. They make 10 visits a year. The amount of assistance they get is quite great. And that's why it worked. We learned through this 10 years of doing all these randomized control trials, the dose that it would take for a school to be able to do this.
So then, Michelle, you probably have a little more detail that we could visit about later on cost per school and what that looks like is.
Yes, Mr. Chairman, I believe you were provided the resources and services broken down per year that BAR provides. You'll note at the top that the cost for school is $80,000. However, they do provide rural pricing as well. So Dustin and I did sit down with BAR and look at enrollment numbers in the state to see potentially where we could group schools and districts together to reduce some of the costs. And so happy to provide that work to you with the.
Yeah, so that's
actual-
240K in sum total, in 80K a year.
Yes, 80,000 a year.
Yeah. So, 80,000 per school, regardless of the size of school.
Well, and that's where we were combining some of our rural schools treat them as a school with combined because of the low enrollment.
Okay.
So it reduced our numbers. I can't recall from 360 plus down to 2 something, but happy to provide the specifics
Yeah,
on that.
I just need to chew on that bone a little bit.
Absolutely.
Okay, thank you. Thank you, guys.
Mr. Chairman, thank you so much. Thank you, committee members. Appreciate your time.
Michelle, before. Well, I've screwed this schedule up so bad today, and we're now at our 12:12. Are you okay if we're going to go to lunch? We're going to get with Mrs. Meyer and go see St. Joseph's. Come back. I'd like to finish up our first component, go through public comment on that, and then come back and finish that. Are you okay with them?
Yes, Mr. Chairman, I am happy to stay and be available.
Okay, thank you. So, Mr. Chairman, Miss Myers, can you kind of give us how this is going to look on our tour of St. Joseph's? Okay, and staff, remind me how much time we allowed for this? Okay. Yeah, so Rhonda, we're trying to make up a little space, so cut us short, if we can eat our Fritos as we're walking maybe. But if you can get us back here, a little before 1:30 where we can start. Thank you. Thank you.